السلام عليكم حضورنا الكرام. سنبدأ المؤتمر بالنشيد الوطني بعد قليل. Ladies and gentlemen, we will start the conference with the national anthem in a moment. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين الذي أوحي إليه بأول كلمة من رب العرش العظيم: اقرأ. فصلى الله عليك يا سيدي وشفيعي وملهمي يا رسول الله. بكلمة واحدة وهي كلمة اقرأ بدأت رحلة البشرية في البحث عن أصل الأشياء وتكوينها، وأصبح السؤال الشاغل بكيفية تطويعها والاستفادة منها. وليس بغريب بأن مهنة الصيدلة، والتي تعتبر من أقدم المهن، قد اعتمدت بشكل أساسي على القراءة والتجربة واكتشاف عوالم أخرى لخدمة البشرية. السيد مدير الجامعة بالإنابة الأستاذ الدكتور مشاري لافي الحربي، السيد أمين عام جامعة الكويت بالإنابة الأستاذ الدكتور فايز منشر الضفيري، والسيد عميد كلية الصيدلة بالإنابة الأستاذ الدكتور ميثم عباس خاجة. حضورنا الكرام، كل الشكر والامتنان لحضوركم في هذا اليوم الذي يشهد افتتاح مؤتمر الكويت الدولي الثامن للصيدلة تحت شعار التطورات في اكتشاف الأدوية وتوصيلها والصيدلة السريرية، كن ملهماً. جزيل الشكر والعرفان للراعيين الرسميين لهذا المؤتمر، جامعة الكويت ومؤسسة الكويت للتقدم العلمي، وإلى كل من ساهم لوصولنا لهذا اليوم الذي طال انتظاره بعد توقف دام ما يقارب 5 سنوات. فما أجمل هذا الانتظار الذي توج بعقد هذا المؤتمر في مدينة صباح السالم الجامعية وفي مركز المؤتمرات بجامعة الكويت. نعم، جامعة الكويت 57 عاماً، عراقة تاريخ وجودة تعليم ومستقبل أجيال. فليتفضل مدير الجامعة بالإنابة الأستاذ الدكتور مشاري لافي الحربي لإلقاء كلمته.
بسم الله والحمد لله، وأصلي وأسلم على المبعوث رحمة للعالمين سيدنا محمد وعلى آله وصحبه أجمعين. الأستاذ الدكتور فايز منشر الضفيري أمين عام الجامعة بالإنابة، الأستاذ الدكتور أسامة مهوس سعيد نائب مدير الجامعة للعلوم الطبية، الأستاذ الدكتور عثمان الخضر نائب مدير الجامعة للأبحاث، عميد كلية الصيدلة بالإنابة الأستاذ الدكتور ميثم عباس خاجة، العمداء الزملاء أعضاء الهيئتين الإدارية والأكاديمية، السلام عليكم ورحمة الله وبركاته. نرحب بكم في مدينة صباح السالم الجامعية في افتتاح المؤتمر الدولي الثامن للصيدلة، والذي تنظمه كلية الصيدلة في جامعة الكويت بعنوان التطورات في اكتشافات الأدوية وتوصيلها والصيدلة السريرية بعنوان كن ملهما أو ملهما، بمشاركة نخبة من الباحثين والباحثات من داخل الكويت وخارجها. حضورنا الكريم، إن هذه المؤتمرات هي منصة مهمة وبارزة لتبادل المعرفة وتوثيق التعاون بين الباحثين وأعضاء هيئة التدريس والطلاب والعاملين في مجال علوم الصيدلة، كما يمكن تقديم أحدث الابتكارات والمستجدات في اكتشاف الأدوية وتوصيلها من خلال هذا المؤتمر، بالإضافة إلى مناقشة آخر المستجدات الحاصلة في الصيدلة السريرية والتحديات التي تواجه هذه المهنة الإنسانية. كما يسعدنا أن يكون لدينا 5 من المتحدثين إقليميين ودوليين متميزين من جامعات ومؤسسات عريقة في ألمانيا والمملكة العربية السعودية والإمارات العربية المتحدة، بالإضافة إلى العديد من المتحدثين من جامعة الكويت ووزارة الصحة. الحضور الكريم، إن جامعة الكويت تحذو نحو التميز والإبداع المحلي والإقليمي والدولي، وتتبنى طموحاتها بالعمل الجامعي لتحقيق تطلعات أبنائها لمستقبل تعليمي أفضل والمحافظة على الجودة في مخرجاتها وتواجدها المتميز. وقد حظت كلية الصيدلة في جامعة الكويت بالرعاية والاهتمام، وقد حققت العديد من الإنجازات على الصعيد الأكاديمي والبحثي وخدمة المجتمع، كما حرصت على التطوير المستمر للوصول إلى أرقى الخدمات الصحية في دولة الكويت. وبالختام أتقدم بجزيل الشكر والتقدير إلى كلية الصيدلة لتنظيمها هذا المؤتمر، وأخص بالشكر الأستاذ الدكتور عميد الكلية ميثم عباس، وكل أمل أن يكون مؤتمراً عامراً بالبحوث ثرياً بالنتائج وموفقاً بالتوصيات. والسلام عليكم ورحمة الله وبركاته.
والآن مع كلمة عميد كلية الصيدلة بالإنابة الأستاذ الدكتور ميثم عباس خاجة، فليتفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وصحبه أجمعين. الأستاذ الدكتور مشاري الحربي مدير جامعة الكويت بالإنابة، الحضور الكريم، إنه لمن دواعي سروري أن أرحب بكم في مؤتمر الكويت للصيدلة بنسخته 8، والذي تنظمه كلية الصيدلة بجامعة الكويت. كما هو ملاحظ في الآونة الأخيرة تحظى مهنة الصيدلة بمزيد من الاهتمام، وخاصة فيما يتعلق بدور الصيدلاني المهم بمختلف تخصصاته كجزء لا يتجزأ من فريق الرعاية الصحية والخبير في توفير أحدث المعلومات القائمة على الأدلة العلمية الرصينة فيما يتعلق بالاستخدام الأنسب والآمن للدواء. في هذا المؤتمر نهدف إلى جلب الخبرات في هذا المجال المهم والحيوي من العلوم الصيدلانية الأساسية والسريرية، لتبادل المعارف والمهارات التي ستؤدي في نهاية المطاف إلى تحسين جودة البحوث في الكليات والمعاهد البحثية، وعلى جودة الخدمات الطبية المقدمة للمجتمع. أتمنى لجميع المشاركين مؤتمراً ناجحاً، وأن يكون هناك مزيد من التعاون العلمي والبحثي على الصعيدين المحلي والدولي. ومن خلال هذه المناسبة أود أن أتقدم بفائق شكري وامتناني العظيم إلى كل من شارك في إنجاح هذا المؤتمر من لجنة منظمة وباحثين وحضور كريم ودعم لا محدود من الإدارة الجامعية. وفي الختام أتمنى للجميع الاستفادة من المحاضرات العلمية وورش العمل التي سوف يتم تقديمها خلال هذا المؤتمر، وإلى الزوار الأعزاء طيب الإقامة في بلدهم الثاني الكويت، والسلام عليكم ورحمة الله وبركاته.
Acting President of Kuwait University, Prof. Mashar Al-Harbi, and Acting Secretary General, Acting VP HSC, and Acting Dean of College of Pharmacy, to all the guests who are attending, academic staff, and students. We would like to welcome you again on this lovely morning and would like to thank our major sponsors, Kuwait University and KIPC, Kuwait Foundation for the Advancement of Sciences, for organizing the KIPC 2024, the 8th Kuwait International Pharmacy Conference that emphasizes the advancement in drug discovery, delivery, and clinical pharmacy. We all know how people are stereotyping pharmacists. Not me. But we all see that the profession goes beyond drug dispensing. It all started with curiosity that led to an experiment filled with trial and error, lots of errors and ups and downs, but with patience and determination, which by the end led to knowledge and a discovery, drug discovery. A pharmacist has become a vital part of the healthcare team, working alongside physicians to optimize patient care with unique blend of medical knowledge and personal connection. Kenneth G. Wilson once said, "The hardest problems of pure and applied science can only be solved by the open collaboration of the worldwide scientific community." And here we are. Stay inspired. Ladies and gentlemen, that's all for me. I proudly present the Assistant Professor of the Department of Pharmacy Practice, College of Pharmacy, Kuwait University, and the Chairperson of the KIPC 2024, Dr. Fatma Rashid.
On behalf of the organizing committee, it is my pleasure to welcome you to the 8th Kuwait International Pharmacy Conference. This conference is the perfect blend of learning, networking, and I am extremely pleased that you could join us once again after almost 5 years since the last conference. Before I give you a glimpse of our scientific program, I would like to take this opportunity to thank all the people that made this conference possible. We started about a year ago, and it was not easy. However, with a great team, we were able to pull it through. And I hope all pharmacists and students alike will take advantage of this program. First, I would like to thank the scientific committee for their help in creating the scientific program. And I would also like to thank the logistic committee who guided me through the administrative maze. It was not easy, it was a lot. However, we were able to pull through it. I would also like to thank the volunteers from the Ministry of Health, particularly Mubarak Al-Kabir Hospital and Jabir Hospital, who are helping me to run this conference today and tomorrow. And I would also like to thank the volunteers from our past graduate and student who are also helping. Finally, I would like to thank the Acting College of Pharmacy, Professor Maytham, for giving me this opportunity of leadership. This two-day event will be dedicated to cover a wide spectrum of sessions, including poster sessions, presentation, and a workshop. And we're delighted to have more than 10 speakers, five from international and regional regions, and also speakers from distinguished university and institutions from Germany, Saudi Arabia, and United Arab Emirates. And day one of the program is dedicated to pharmacology and drug discovery, and then on day two, we will be having a clinical pharmacy as well as drug delivery. I hope this program will inspire you all to sharpen your vision, achieve your individual goals, and while further enable you to discuss any current issue and relevant issues in the pharmacy world. And again, on behalf of the organizing and scientific committee of the College of Pharmacy, I welcome you. And I sincerely hope that you take this opportunity to network, learn, and share your experience. And before we start our scientific program at 10 a.m., please feel free to enjoy our refreshments as well as the poster sessions and the booth. Thank you.
Have your attention, please. Okay. I'd like to welcome everyone this morning for the inauguration of the Kuwait Pharmacy International Conference, the 8th one. And we have an exciting first session this morning with 3 prominent speakers covering the areas of cancer, cardiovascular pharmacology, and diabetes. Our first speaker is Professor Maitham Khaja, and Professor Khaja has joined Kuwait University in 2009 and as assistant professor after taking a scholarship on behalf of Kuwait University, and he progressed through the ranks and became a full professor in 2018, and at the same year he also became chairman of the Department of Pharmacology and Therapeutics, and currently since 2022 he's been the acting dean of the College of Pharmacy. Professor Khaja has published in several reputable journals, many world-renowned publications, and has won the prestigious award for the Young Research Award from Kuwait University in 2013 and the Jaber Ahmed Young Researcher Award in 2019-2020 from the KIPC Foundation. Today he's going to talk about cancer environment. Does it matter? I'd like to introduce Professor Khaja to the podium to speak. Thank you.
Thank you very much, Dr. Qaddoumi. So today we will try to present our latest data or evidence regarding the role of the cancer microenvironment or the area surrounding the cancer. Does it matter? Does it help or have a role in cancer progression or not? So maybe I would like to present some data, and hopefully by the end of the presentation we will be able to have an idea about the role of the microenvironment in cancer progression, particularly with breast cancer. So breast cancer is considered one of the major diagnosed neoplasm and the leading cause of cancer mortality among females worldwide. A recent publication came in 2022 suggesting that from all GCC countries, the highest rate of breast cancer incidence was in Kuwait, followed by United Arab Emirates, Bahrain, Qatar, Oman, then Saudi Arabia. So Kuwait was the leading GCC country in the incidence of breast cancer. And also in that paper, they showed that about 40% of all cancer cases in Kuwait are breast cancer. So we are talking about a huge health issue, particularly in Kuwait. As we know that estrogen is a very important hormone for the production or the reproductive system, and also it has a very important role in other systems, including cardiovascular, immune, musculoskeletal, so it is not only limited to the reproductive system. But in relation to breast cancer, estrogen plays a very important role in cancer cell proliferation and progression. And one of the main targets for treatment will be targeting estrogen or reducing the synthesis of estrogen or targeting the receptor, which is estrogen receptor. And these anti-hormonal therapies are very important in the treatment of any breast cancer patient. We have different stages of breast cancer. We go from a more localized lump in the lobules or duct of the breast, and it might go to the nearby lymph nodes and spread to other areas in the body. And we have different staging. The whole idea is that it is a progressive disease. Once you target it from the beginning, the management will be much easier. And we know that during the treatment or the course of the disease, we have a lot of alternations which will affect also the progression and the choice of a treatment. And this is what is shown here. Breast cancer is a very complex disease. And it is not only based on the staging, but also on the subtypes. So based on the subtypes, we need to determine the best treatment approach. And when we talk about the subtypes, we have 3 main receptors, or 4, which if the cancer cells express these receptors or does not express, the choice of a treatment and the prognosis will be different. And we are talking here about the progesterone receptor, estrogen receptor, human epidermal growth factor receptor, HER2, and urokinase plasminogen activator. So when we talk about only estrogen receptor, we have 2 main types of breast cancer, either estrogen receptor positive or negative. So negative means these cancers does not express estrogen receptor, and therefore we cannot use anti-estrogen therapies. When we talk about estrogen receptor positive, these cancer cells express ER, and we can target them through tamoxifen or aromatase inhibitors, modulating the level of estrogen in the body. The problem with breast cancer is about 30% of cancer cases, they do not express estrogen receptor. And the problem is not only that you are not allowing these patients to have a choice of anti-estrogens, but the only option for these patients will be chemotherapy. And we know the side effects, the resistance with chemotherapy, and the patient survival rate, side effects, it's very unpleasant. And cells which do not express estrogen receptor, they have advanced prognosis. And these cancer cells are more aggressive in terms of proliferation, in terms of motility, in terms of invasion to other organs in the body. So it is a very aggressive type of disease, not responsive to estrogen therapy. And what we call it de novo resistance. So from the beginning, they don't express estrogen receptor. And these patients have poor prognosis. Some of the patients which had estrogen receptor in the beginning, which are around 70%, around 50% of them, they lose estrogen receptor during the treatment. So they become resistant to estrogen during the treatment approach, and that's why they need to be shifted to chemotherapy, and again, they have poor prognosis. As we said, that estrogen receptor expression is very important because we can target these estrogen receptor cancer cases with either antagonists for the estrogen receptor like tamoxifen, which compete with the estrogen on the binding site, or using aromatase inhibitors which inhibit the synthesis of estrogen. And as we said, that these are not an option for an ER negative cases. So what is the problem or mechanism of endocrine resistance, which is cells not expressing estrogen receptor? Many growth factors, they can induce the activation of the estrogen receptor independent of the ligand, which is estrogen. So they have a continuous activation, uncontrolled activation downstream the estrogen receptor, which will lead to enhanced cell proliferation, motility, and invasion, which will lead to poor prognosis. You can have a lot of upregulation in some of the co-activators or downregulation of the co-repressors activity. And in many cases, resistance will be due to estrogen receptor mutation. So you have unfunctional estrogen receptor, which will lead to resistance to endocrine-based therapies. So how this resistance occurs? We have a general phenomena which is called epithelial to mesenchymal transition. So this transition is where we have epithelial type of cells, which is the normal breast cancers. A lot of growth factors, epithelial-derived growth factor, endothelial growth factor receptor, insulin-like growth factor, and a lot of downstream signaling molecules like mTOR, PI3K, MEK, RAF, RAS, ERK, mTOR, they induce a transition to a mesenchymal phenotype. So these cells, being epithelial, they become mesenchymal. It's like having an apple changed into orange, something totally different. These mesenchymal cells have a characteristic of increased mesenchymal marker, like we will talk about them in a minute, and reduced expression of epithelial marker. They have loss of estrogen receptor, so they are resistant to endocrine therapy, and loss of sensitivity to anti-estrogen therapy, and they are characterized by increased proliferation, motility, and invasion, which will lead to poor clinical prognosis. We have our cell model in our lab where we induced a transition from an epithelial cancer into a mesenchymal cancer by knocking down the estrogen receptor. So we induced an shRNA to knock down the estrogen receptor on these cells, which are called MCF7. They express the estrogen receptor and they are epithelial in nature. When we knock down the estrogen receptor, these cells become mesenchymal. They lost the expression of ER, and they have increased expression of mesenchymal marker, reduced expression of epithelial marker, high proliferation, high motility, high invasion, very aggressive type of cancer. We had tried to knock down the estrogen receptor in another cell line, but we failed to downregulate estrogen receptor, so we are using these cells as a control. So they have the plasmid, but ER is still expressed, and we are using it as a positive control. This is some data which shows that these parental cells, which are estrogen receptor positive, they are non-invasive. So this is agarose spot assay. These are the cells. They are unable to invade the agarose. So they are very benign, non-invasive. On the other hand, these ER negative cells, which are mesenchymal, they are highly invasive inside the agarose spot, which shows that they are very aggressive. Again, these cells, their proliferation is not responsive through estrogen because they don't have estrogen receptor, and tamoxifen or any anti-estrogen therapy will not reduce their effector function because, again, they don't have estrogen receptor. What about the microenvironment? Any cancer, it's not a pure, any cancer lump, when we talk about solid tumors, it is a consist or a mixture of heterogeneous type of cells, mediators, cytokines, chemokines, growth factors. So it is not a homogeneous lump of cancer cells. There is a lot of cells, immune, non-immune cells, are part of this cancer lump, and they always play a role in the behavior of the cancer cells. And we have different types of cells like cancer-associated fibroblast, macrophage, we have mesenchymal cells, we have dendritic cells, we have stromal cells, we have lipocytes, we have a lot of mediators like cytokines, chemokines, growth factors. All of them are part of this big lump which represent cancer. And all of these have a role. They are not there for no reason. They are there for a reason, and the problem that they play a very important role in the cancer progression, and one way to control the disease is through targeting these cells or mediators which surrounds this microenvironment. The three major players in the microenvironment are the pH of the tumor, lactate or the amount of lactic acid, and hypoxia or less oxygen. These are the three main mediators which we studied extensively, but here I am only showing some data regarding the contribution of each one of them. So the question is there a role for the microenvironment in cancer progression? let's see if they have a role or not. Let's talk about the pH to start with, which is one important player in the cancer microenvironment, and there is not a lot of attention regarding the pH surrounding the tumor. In general, in a normal cell, you have a pH inside the cell which is around 7.1 and a slightly alkaline pH in the extracellular environment which is around 7.4. In cancer, there is what is called reversed pH gradient. So what happens that you have a more acidic extracellular environment. So the idea that the pH surrounding the tumor is acidic in nature. And these data came from in vitro studies. We don't have an absolute data showing in vivo that the cancer cell or the microenvironment is acidic, but this is the general idea that the outer environment is acidic in nature. So it's only pH. Well, I mean, what does it affect? It does a lot of things, and there is a lot of theories regarding what the acidic pH does for cancer cells. And here we are talking about different types of cancers, not only breast cancer. They kill the normal surrounding cell, promoting the proliferation of the cancer cells. They enhance angiogenesis and metastasis. They suppress the immune response to the tumor, which is bad. And they induce chromosomal instability and increase a lot of proteases which are able to degrade the extracellular environment and higher chance of invasion. So these are theories regarding what acidic pH can do. The question is this a normal or general phenomena in all cancer cells, or there are always exceptions? I don't think that cancer can be treated equally or seen as one type. Even if we talk about a breast cancer, we talk about a lot of subtypes, and each one has its own unique characteristic. And that's why we need personalized treatment based on the type of each cancer. So, let's set the stage. We tried to culture our cells in acidic pH media. We did not see any change in terms of morphology, proliferation, motility, invasion. So in our hands, we don't see any role for the acidic pH in any effector function of the cancer cells. But surprisingly, when you culture the cells in alkaline pH, slightly alkaline, I'm talking about 8.3 as the maximum, but any change can happen within up to 7.6, 7.8. And this is only happening in estrogen receptor negative breast cancer cells, not the estrogen receptor positive. So only in the mesenchymal, highly proliferative cells, alkaline condition does something for them. What we noticed that when we put our P2 cells, which are ER negative, in a normal pH, neutral pH, this is how they look like. And this is a higher magnification of the cell. This is their normal look. When you put them in alkaline condition, within 10 minutes, see the rounding, these cells become shrunk and they produce a lot of blibs or extensions on the outside membrane. This is reversible, completely reversible if you put them back in neutral pH. So this is a physiological phenomenon. You put them in alkaline, they become round, spherical. Put them back in normal pH, they become like this again. So this is highly reversible. So what? We have a very short video which shows I think I cannot. Anyway, this video shows in real time. It will be nice to show it. How the cells are changing, or maybe, let's see. Yeah. See the cells? See how this is within 10 minutes. These cells become rounded and they form these blibs on the outer membrane,
which is highly dynamic. They are moving blebs. So this is how they look like if we keep them in the alkaline condition, and this is reversible when we put them back in a normal pH. We used electron microscopy to have a bigger image, more clear image of our cells. This is how a P2 cell in a neutral pH look like. A lot of lamellipodia, which are extensions needed for them to move. Within 10 minutes of pH, this is how they look like. This is exactly the same cell. See the dramatic change happening within 10 minutes. And this is reversible. You can reverse it back when you put them in neutral pH. So this is only in alkaline pH. We were able to show that actin cytoskeleton is the major component of these blebs. So when we use cytokilasin, which is an actin polymerization inhibitor, we were able to inhibit these blebs. So these are cells treated with actin cytokilasin, and you can see that they are not forming any blebs. We were able to inhibit these blebs, see how dynamic they are, with Rho inhibitor, which is important for actin cytoskeleton. We also used myosin light chain kinase inhibitor, which is needed for the actin-myosin interaction, and these blebs are prevented. So actin is a very important player in these blebs. So what? So what? I mean, you have blebs, then what? What is the functional consequences? We think that these blebs have a role in motility or invasion. One way to show that, we culture a cell in a gradient of a chemoattractant. So we have a source of a mediator which attract the cell. And once you have a gradient from one side, the cells will become polarized toward the side of chemoattractants to move. So when we have a negative control, which is PBS, it is not a chemoattractant, and you stain the cells with actin dye, the actin is uniformly distributed because the cells are not in a moving position. Once you have a growth factor or a chemoattractant, see the actin ruffling or membrane ruffling, you see a more concentrated actin facing the source of chemoattractant. And these cells are able now to move toward this chemoattractant by forming redistribution of actin mainly in an area facing the growth factor. So if you put the cells in alkaline condition, blebs are all over the place. See what they do? They are more polarized toward the source of the chemoattractant. So these blebs are in a polarized condition, which shows that they might have a role in motility or invasion. We showed that signaling pathways, a lot of signaling molecules will be shut down when you put the cells in alkaline condition and back to normal when you are putting them back in a neutral pH. So it's like an off, so on, off, on. It's a highly reversible. So ERK is phosphorylated at normal pH, shut down with alkaline, back to normal with neutral. P38, on, off, on. AKT, on, off, on. So it's highly reversible. And you have a pan shutdown of signaling molecules. Total AKT is just for a loading control. It is there. So it's only the phosphorylated active form of AKT, it's shut down. Molecules related to cell motility, junctional adhesion kinase, focal adhesion molecules, integrins, all of these molecules play a role in cell motility, and they are upregulated with alkaline condition, back to normal with neutral. So you have integrin, it is up, then slightly down. Focal adhesion kinase, this is a neutral, alkaline, back to normal. So you see upregulation of signaling molecules and, adhesion molecules. All heat shock proteins are upregulated, which shows it is a stress response to the cell. So they don't like it. They don't like this alkaline condition, And that's why all of the heat shock proteins are upregulated, which shows that the cells are under stress. Many molecules, we showed that their distribution are localized into the form of blips, which means that they have a role, these blips have a role in cell invasion, because many of these molecules like integrin, this is how it looks like in neutral pH. See, they are mainly in the blips in alkaline condition. The same for junctional adhesion molecule. They are part of the blip. See, focal adhesion kinase, this is the amount of expression in neutral. This is how much it is expressed in alkaline condition, and they are part of the blip. So not all molecules are part of the blip, some of them which are only involved in motility and invasion. We were able to inhibit this phenomena with many ion channel inhibitors like sodium hydrogen, sodium potassium, ATPase. We were able to inhibit this. So it's not only with actin cytoskeleton inhibitors, but also with ion channel inhibitors. So what? We show invasion. This is the degree of cell invasion in a P2 cell in response to neutral environment, neutral pH. They are highly invasive. This invasion becomes significantly higher if you only expose the cells to alkaline condition for 1 hour. So they become more invasive with alkaline condition. Let's measure the amount of matrix metalloprotease, or MMP2 and 9, which is an indication of aggressiveness of the cell. Because the more you secrete, the more chance of degradation and invasion. This is the P2 in neutral condition. This is the amount of MMP released. When you add a growth factor, which enhances motility, you see upregulation in MMP. But see, when you put the cells in alkaline, they secrete more MMP than an EGF, which is a potent growth factor. They secrete more. And if you add EGF to the picture, even more. And you were able to inhibit this increase with ion channel inhibitors, which shows it's related to the blip. When you put the ER positive, which are not changing with the alkaline condition, no change with MMP, because it is only for an ER negative cell. We showed, okay, so there is secreted factor. So can we use this secreted factor, adding them to a cell which were not exposed to alkaline condition, and see what happened? Well, actually, we cultured the cells in response to alkaline condition. We took the culture medium, which mainly have a lot of growth factors. We added them to cells which were at neutral condition, neutral pH. These cells become more invasive. So it's not only the shape change, but also the secreted mediators can enhance invasion. So what we are proposing, that during the epithelial to mesenchymal transition, where cells become epithelial, they become more mesenchymal through ER downregulation. Now we show that in response to alkaline condition, we have what is called mesenchymal to amoeboidal transition. So we have another transition to an amoeboidal shape, which is more spherical, easy to move and metastasize, in addition of secreting a lot of growth MMPs for example, which enhances invasion. I told you that it is a stress response. So if you keep the cells in alkaline condition for too long, cells will die. And this is what happened. Overnight, you have a lot of nuclear degradation. And when you measure cell viability, it is down. So it is a stress response. Only exposure up to 4 hours. Beyond 4 hours, it's harsh. Cells will die. So what we are proposing, in knocking down estrogen receptor, we have epithelial to mesenchymal transition. Cells, through exposure for alkaline condition for a very long time, it induces cell death. Short time, you can see blips, which can be inhibited by a lot of inhibitors. These blips show directional movement toward a source of chemoattractant, and they have secreted factors which can promote invasion. Let's talk briefly about the other part, which is lactate. In general, lactic acid is very important and part of the microenvironment of cancer cells. And the more lactic acid the cancer cells secrete, the high chance of invasion and prognosis. So highly invasive cancers, they have high level of lactate. And the more lactate, the more invasive the cancer is. We have different lactate is mainly secreted through lactate dehydrogenase enzyme. This is the major enzyme for lactate synthesis. And there are 4 main isoenzymes, A, B, C, D. In cancer cells, A and B are mainly the main 2 isoforms. What we showed in our hands when we do a real-time PCR, that LDHA is present in both ER positive and negative. Both of them, they have estrogen receptor. But see, the LDHB isoenzyme, it is only expressed in ER negative. It is not in ER positive cells, it's not there. We confirmed that by Western. If you can see, LDHA is in all cell lines, B only in the ER negative cells. So they have A and B, while the less invasive have only A. What is the consequences of that? LDH activity, the enzyme activity, is much higher in ER negative. Lactate level is much higher in ER negative than ER positive. So they secrete more lactate because they are more invasive. When we used an siRNA technique to knock down either the A or B isoform in ER positive or ER negative, LDH activity is down, lactate level is down, cell motility is down. So when you knock down LDHA or B, the amount of lactate is less, cell motility is less. So I'm reducing cell motility by knocking down LDHA enzyme and reducing lactate level. So we thought, let's have cells which are P2 or the ER positive cells which are not invasive. We culture them in a media which contains a lot of things, including lactate, from an aggressive cell. These cells become more aggressive. A benign with a culture of invasive cells, they become more invasive. When you take invasive cells and you culture them with ER positive, which is less invasive, they become less invasive. So the media plays a very important role. So again, it is not only lactate in the media, a lot of things in the media. So we thought, okay, let's focus only on lactate. When you use the poorly motile cell, ER positive cells, which secrete less lactate, their motility is very little, it's like 20%. When you add increasing concentration of lactate, they become more invasive. So lactate is very important in cell invasion. And when you add pyruvate, which is another product which will be converted into lactate inside the cell, also increases cell motility. So what does lactate do to increase cell motility? We showed that ERK phosphorylation, one of the major downstream targets, is upregulated when you culture them in lactate. Another point to consider, when you put the cells in lactate for a very long time, they die. So it is a stress response. So this is similar to alkaline condition. Aggressive, increased aggressiveness, prolonged incubation, death. Lactate, increased aggressiveness, prolonged culture, death. Bear this in mind. We also used another pharmacological inhibitor of LDH, like oxamate, lonidamine, and GNE, and we showed the same effect. Less LDH activity, less lactate, less motility, less invasion. So we confirmed that by a chemical inhibitor or siRNA-mediated knockdown of LDHA or B isoform. The last point which I would like to emphasize, hypoxia. Hypoxia, where there is less oxygen in the core of the tumor. And there is data which shows that the PA or the percent of oxygen in many tumors, like the brain, so the normal brain, the amount of oxygen is about 4.6%. Brain tumor only 1.7, so there is less oxygen. Breast 8.5, 1.5 breast cancer. Normal kidney cortex 9.5, kidney tumor 1.3, lung 5.6, 2.2. So it is a general phenomenon that hypoxia is very important characteristic of any solid tumor. When we talk about hypoxia, there is a role for hypoxia? For sure. They increase tumor vascularization, induces chemoresistance, induce epithelial to mesenchymal transition, which is more aggressive type of cancer, and enhances cell metastasis. So hypoxia play a very important role in cancer progression. But let's think about it. When they say hypoxia increases cancer aggressiveness, we are talking about cells in the middle, because oxygen is less in the core, not in the periphery. So one important question to ask, cells which are invasive are coming from the core all the way down and they metastasize, or it is easier for the cell which is already in the periphery to metastasize? But when we say hypoxia, hypoxia is in the middle, not in the periphery. So there is no publications regarding a cell which can invade another cell. Because in general, you have a cell, a porous membrane, and they invade. But if the cell, and there is another barrier of another cell, can they invade so that they become into the periphery and move? We don't know. Nobody tried that, to be honest. Nobody showed that the cell can bypass or invade through another cell barrier. So, and for us, we thought if hypoxia, then these cells should move through another cell line before reaching the periphery, which is an important question, but nobody answered it. Nobody actually did any experiment to show that. So we tried to show that. First, we simulated hypoxia by a chemical compounds like DFO or cobalt chloride. And we showed that hypoxia, HIF1 alpha, which is an indication of hypoxia, is upregulated. So we were successfully inducing a state of hypoxia in our cells. But the amount of hypoxia in our aggressive P2 cell is much more than the other cells. Here we are talking about 1,000 picogram per ml. Here we are talking about 4,000, so 4 times more. Hypoxia in general reduces cell proliferation, so it is unpleasant stress condition, but increases motility. So what is common now? Lactate, alkaline, hypoxia, more motility, less proliferation. It's a coincidence, or what? I mean, this is a very consistent in all of these players. First, we ask a question: can a cell invade another cell? Because if it cannot, then the whole idea of hypoxia and core is irrelevant, because the cell cannot invade another cell, right? So we put a cell, or our P2 cell, in a basement membrane extract, which is a porous membrane, representing the blood vessel vasculature as an indication of invasion. They are very invasive. When you put cells with another barrier of cells, so these cells should penetrate barrier number 1, then barrier number 2. They are still invasive, but not as much as a cell which was only phased with a basement membrane. When you add a state of hypoxia, you have a trend of increase, but it's not significant. So we are showing that the cell can invade another cell, but it is more difficult. Let's have a co-culture experiment. We put 2 dyes, red dye and blue dye. A blue dye for a benign breast cancer, red dye for aggressive breast cancer. We did 2 ways. We cultured them together. So we are asking a question: can an invasive cell move into this direction or this direction occupied by other cells? Can it penetrate or squeeze? Yes, it can. So up to 4 days of culture, we have cells moving toward the either sources of chemoattractants. When you add cobalt chloride, more cells are invasive. So hypoxia increases the amount of invasion in a co-culture. We have another situation where we have cells asking them to move, penetrate, through. Can they do that? Yes, they can. So our P2 cells can move inside this layer and beyond. And when you have cobalt chloride, which is an indication of hypoxia, more cells are moving here and beyond. So cell can invade another cell. Hypoxia enhances this effect. So in conclusion, hypoxia reduces cell proliferation, increase motility and invasion. So I finish by this question. Why do people migrate? Why? When there is a war, starvation, or a harsh environment. When I put any human being in a harsh environment, I force him to move. Because migration is risky, right? You don't know where you are going, and you are leaving your homeland. So why you do that if you are in a very peaceful situation? I will not do that, right? But if I force you, I cut electricity, power. What is happening in Gaza is the same scenario now. Cutting electricity, power, forcing people to move, right? So this is logical. Why a cancer cell move? It is already in a tumor with its nearby siblings. Why some, and in general, we have only 1%, less than 1% of cancer cells, they invade. Not all the tumor cell, the lump will invade, only specific little number of cells. Why? Why it go through a bloodstream, facing immune cells, they might die, go to another secondary organ, forming a new colony. Why should I do that? Unless I force the cancer cell to move. What I am proposing, that these microenvironments are creating unpleasant situation for the cells to die and forcing them to move by increasing their motility and invasion just to escape. And this escape will allow forming a secondary tumor. So the cancer microenvironment induces a state of unpleasant situation for cancer cells, forcing them to move to become invasive. So targeting the microenvironment will, I think, play a very important role in controlling cancer metastasis, allowing the cancer to have a very nice, pleasant state to stay without forcing them to move. I would like to thank KU Research Sector for funding many grants, KFAS, core facility in the HSC, and a lot of collaborators and MSc students. Thanks for your attention.
Thank you, Professor Khaja, for this wonderful talk about the mechanism of endocrine resistance in breast cancer. He's obviously enlightened us a lot about how the microenvironment plays a big role in that. And we're looking forward to more exciting research in the future from him. Our next speaker for today's morning session is Professor Pierre Moreau. Professor Pierre Moreau has obtained his Bachelor of Pharmacy and his PhD at the University of Montreal in the area of cardiovascular pharmacology. He then went on to do his postdoc at Bern University Hospital. And in 1997, he managed to join University of Montreal as an assistant professor, where he developed and specialized in his research in the area of hypertension. He published several publications, 95 peer-reviewed articles in prestigious cardiovascular journals in the area of vascular aging and remodeling and stiffness. He progressed through the ranks at University of Montreal until he became a full professor in 2007. And a year before that, he became the Dean of the University of Montreal, where he served until 2014, helping develop the curriculum and the transformation at the University of Montreal of their undergraduate program. We were lucky to recruit him at Kuwait University in 2014, where he joined us as a full professor and dean of the College of Pharmacy in 2014, where he stayed with us as a dean till 2022. And at that time, he prominently served to basically transform our undergraduate program from a Bachelor of Pharmacy to full-fledged Doctor of Pharmacy program, and enabling the development of competency-based education in the region. I'm very pleased to welcome Professor Pierre Moreau to the podium, where he will be talking this morning about his talk on mechanism of vascular stiffening. Please welcome Professor Moreau.
Thank you. Well, good morning, everyone. Thank you, Mohammed, for the nice introduction. And I think from Maytem's presentation, nobody forced me to move to Kuwait. Maybe the harsh environment of Canada with the harsh winters. Of course, the weather is much nicer in Kuwait. I hope I don't feel, you don't feel like I'm a cancer coming to Kuwait. I'm going back anyway, so it's reversible. There's no problem. Okay, so I'll talk to you about the research we did when I was still in Canada. And first, I would like to thank the granting agencies, my MSc, PhD, postdoc students that worked with me over the years while I did my research, and trying to give you a perspective of what we did, but also with a kind of a 10 years view of what it means today and what therapeutic strategies are emerging to try to alleviate vascular stiffness, and a special focus on vascular calcification. So I'll answer or try to answer three questions. Why it is important to talk about vascular stiffness, how it develops, and what can we do about it? Okay, because it's not a matter of will you get vascular stiffness, it's when. Everybody will get that if you live long enough. So the risk factors to develop vascular stiffness is aging. Obesity will accelerate vascular stiffness and aging. Diabetes is also something that will cause this acceleration, and we know that hypertension and chronic kidney disease are also risk factors for the development of vascular stiffness. And on the graph, what you can see, I'm not sure if you don't see the mouse anyway. So on the graph, you see the pointer doesn't work. The aortic artery, which is a large artery made of a lot of extracellular matrix, mainly elastic tissue, gets stiffer with time. So from year 10 to year 70, you see this increase in stiffness, while more muscular arteries like we have in the arm and the legs don't get this stiffness. Okay, so it's a disease of large arteries. Okay, so vascular stiffness is mainly observed in larger arteries. Oh, okay, thank you. So what is the importance of having this elastic portion of our vasculature? So when, of course, the heart pumps, it pumps and then it stops. So there's always this pulsatile flow, and this is absorbed by the large arteries that are elastic. So it absorbs the pulse, and during diastole, the flow will continue when the vessels are actually coming back to their normal, let's say, structure. So this, you can see here on the image, Yeah, you can see here on the image that the artery is inflating in a way and then deflating during diastole so that you get a more sustained pressure through the system. But if your arteries are getting stiffer, then you lose this capacity. It's called the Windkessel capacity. So you have these arteries that are more rigid. The flow will go through without this buffering, and it will go through faster. And because it does that, you will get an increase in the pulse pressure. So the difference between diastole and systole will increase. So when you have vascular stiffness, you have reduced diastolic flow, which is important also for the heart, will get less oxygen, reduced diastolic blood pressure, increased systolic blood pressure, and of course the difference between the two, the pulse pressure is also increased with time. And this is what we see in patients. So for instance, this is a graph showing the pulse pressure in men in red and female women, and you see that this increases with age. Again, from 20 years of age to 75 years of age, you see this increase in pulse pressure, suggesting that the arteries are getting stiffer as we age. And this is a kind of a depiction of what happens to the pressure itself. So as you see, as we age, again, from 30 years of age to 80 years of age, our systolic blood pressure increases mostly all the time, but the diastolic goes from a phase where it increases to a state where it decreases. So the pulse pressure increases with time. And when we look at hypertensive patients, so a subset of the normal population, we see that the type of hypertension moves from a diastolo-systolic hypertension, where both levels are high, diastolic and systolic pressures are high, to a situation where mostly the systolic pressure is high and the diastolic pressure is normal, okay? But we have developed drugs and we have been treating patients for reducing both. And is it good to reduce diastolic pressure when it's already normal? Probably not the best. So the development of drugs was aiming mainly at reducing both numbers of pressure, but when we age, it's more the systolic pressure that is elevated, and we don't have necessarily the best products or compounds or drugs to actually improve this situation. And we often see patients with antihypertensive, especially old patients, with hypotension, feeling dizzy. This is because their diastolic pressure is way too low because it's already normal. Okay, so this is something that still needs to be worked on. And you see that after 60, so I'm nearly there, 80% of the population will have isolated systolic hypertension and not diastolic hypertension. So this is a shift in paradigm, because when I started doing research in hypertension, we always talked about diastolic pressure. Then there was a shift mainly brought by the French scientists saying, no, it's the systolic pressure that's important. And there's a lot of evidence, and I'll show you some of them. So basically, there is an impact of having these stiff arteries and this increase in systolic blood pressure. So this from the French group showing that it's an independent risk factor for all cardiovascular disease. So it is by itself, just the stiffness, it is a health problem. Other showing that arterial stiffness leads to cognitive impairment. Okay, so dementia is increased when the large arteries are stiffer. Association between pulse pressure and inflammation as well. And we know that inflammation is something we want to keep as low as possible. Aging, so telomere length associated with, or shortening of telomeres associated with pulse pressure, and pulse wave velocity, which is a measurement of stiffness. It's the speed at which the pulse travels in the arterial bed. So the higher the speed, the stiffer the artery. So it's a measurement. Aortic stiffness is an independent predictor of fatal stroke. Again, all independently, let's say, of diastolic blood pressure, or actually the difference between systolic and diastolic blood pressure. Pulse wave velocity predicts cardiovascular mortality in subjects more than 70 years old. So all these evidence show that there is an impact of having stiffer arteries as we age. This is from a paper from a colleague from Montreal. So we did our PhD together, and we went apart. She went to work on the CNS. I went to work on small arteries, coming back, and we both came back to working on large arteries. And she worked on how arterial stiffness can actually lead to cognitive impairment. And this is her working hypothesis, is that stiffness will increase blood flow pulsatility, and in the brain it's very, very close to the heart, so there will be a lot of changes of pulse. We'll have a reactive oxygen species, gliosis, endothelial dysfunction. The cerebral blood flow will be compromised, neurodegeneration, and cognitive impairment. So this is her working hypothesis, linking stiffness to brain damage. Okay, so hopefully I convince you that it's important to talk about it. I know cancer is also important. These are the main diseases that we have to live with. How it develops, and this is where we did most of our work, trying to understand how stiffness develops, because if we know how it develops, maybe we can target some molecular elements that could be slowing down the progression or reversing what can be done. So this is a schematic of let's say, our working hypothesis. There is, with aging and with stiffness, mechanical stress on the arteries, oxidative stress, and inflammation and repair. And all these things will gradually and slowly break down the elastic properties of the arteries. Okay, so the elastic properties with time will start to have issues based on the environment in the vascular wall. This will lead to two major things. These broken elastic lamellae will be replaced by collagen, which is not elastic, so you get some form of fibrosis. Of course, and a scar is not very elastic, so it will not allow the same properties. But also, this exposed broken elastic lamellae will be prone to harbor calcium deposition. This is the calcification of arteries, okay? And these two things will lead to arterial stiffening. The arteries will become stiffer because they have bone, and when I say bone, it's true. When you have very old calcification, it's like bone, and you have fibrosis. So scarring and bone formation will lead to a stiffer artery. I put cells here with a question mark, because when I talk about this, it seems to be mechanical, only the extracellular environment, the extracellular matrix that is involved, but there's a huge involvement in cells, especially to produce this new matrix and also to contribute to the calcification. And this is where we did most of our work. And this next slide is maybe calcification is assessed. So this slide is something I took from a recent paper. It's very scary. There's a lot of stuff. I won't go through all of this, but it shows you how the cells are actually involved into modulating this stiffening of the arteries. Okay, so if we can look at some processes, I talked about the degradation of the extracellular matrix, so the breaking down of the elastic lamellae. Osteogenic differentiation, so our vascular smooth muscle cells are getting a new phenotype, a bit like in cancer, what we see from normal cells to migrating cells. We see cells that are now changing because of the change in the environment, how they work, what they do. And of course, in vessels, the only type of cells we have besides endothelial cells are vascular smooth muscle cells. So the vascular smooth muscle cells change the way they behave. Okay, so they will start to produce different bone proteins that we don't see normally. Okay, so this will contribute to bone formation. So we see BMP2, for instance, which is bone morphogenic protein. It's something we normally don't see in a blood vessel, but now it starts to be expressed. So we have the reduced anti-calcific protection. We'll talk about a protein called MGP, for matrix GLA protein. This is the main protein we work with. We have an imbalance between phosphate and calcium. Of course, both of them make hydroxyapatite, which is how calcium deposits, also in bone, but also in blood vessels. And we have apoptosis and inflammation that happens there. So I won't go through all the details, but basically we have a couple of things happening in the vascular wall that, let's say, predispose this change of behavior of cells, and now we get to this amplification, if you want, of vascular stiffness over time. So these are a couple of the proteins that are either expressed that are pro-calcification and some that are anti-calcification. And part of them, BMP2, like I said, contributes to the transdifferentiation of vascular smooth muscle cells into osteochondrogenic cells. So again, they're changing their phenotype. They induce osteoblast differentiation, enhance apoptosis, oxidative stress. So all these things are there. And the other one I want to bring is the last one. MGP is a vascular calcification inhibitor that we normally have. So MGP binds to hydroxyapatite, so it binds to this new calcium deposition, trying to limit the amount of calcium deposition, but it also inhibits BMP2. So and this is probably the main effect of lowering the calcification of the calcium we get deposited in our arteries by limiting the expression of BMP2. So this is the protein that we actually work with. So MGP is a protein that needs a transformation after it's being built. So one of 4 amino acids into MGP, matrix GLA protein, are this glutamic acid, and they are converted to gamma carboxyglutamic acid, or GLA. That's why we call it matrix GLA protein. And this is done under vitamin K dependent processes. Just like our coagulation factors need vitamin K, this protein needs vitamin K to be active. Okay, so and then when it's active, it will both bind to hydroxyapatite to limit calcification and bind to BMP2 to limit the action of this bone morphogenic protein. Okay, so this is basically how MGP works. So you can probably all think about, okay, vitamin K, we have drugs that reduce coagulation that are vitamin K antagonists. Should we use them or not? And we will get into that. So basically, what we did is, so basically, if I summarize things, is these vitamin K dependent processes are good for coagulation. They are good for bones. So for instance, one protein, osteocalcin, needs to be activated by the same mechanism to allow bone calcification. But like we just saw, the vitamin K dependent process is important to activate MGP to prevent vascular calcification. So when vitamin K is there and it does its job, I have coagulation, I have bone formation, and I don't have vascular calcification. So it's all good. Now, so in 1988, a group started to develop a model in animals that could reproduce the vascular calcification, of course, in a shorter time frame, because it takes 20, 30, 40 years in humans, so we have to find a way to look at it with something faster. So basically, what they did is that they gave warfarin to rats. And of course, warfarin, if you give too high a dose, the rats will die, they will bleed. Okay, they will have hemorrhage and they will die, so it's not working. Because warfarin will, of course, prevent the coagulation factor maturation, but it will also prevent MGP from its inactive form transform into its active form where it can block BMP2 and also attach to hydroxyapatite, so calcium and phosphate. So what do we do then? Because if we give high dose of warfarin to induce that, we kill the animals. So what they did is they gave a form of vitamin K that can be used by another enzyme to produce the coagulation factors, but this will not, it's not present in the vascular wall, so you cannot, let's say, prevent the activation of MGP. So basically, your MGP is inactive, but your coagulation factors are fine. So with this model, we could show that this is a micro CT image of the carotid arteries, the aortic arch, but they're bent because they had to fill in a micro CT chamber, which is very small. So this is carotid arteries, both of them, the aortic arch, and this is the descending aorta of a rat. And you can see that it's patchy. It's not like everywhere. This is after probably 4 weeks of treatment. So we could reproduce maybe 20 years of aging in 4 weeks. And you see that in some areas, it's very dense. So probably, you know, if you cut here, you will see this very densely calcified area. And here, some other areas are a bit lighter. And this is the media part. So these are the elastic lamellae that becomes calcified because I have inhibited my natural Teflon MGP. Okay, now we didn't change the diet of the rats or anything else, but they become, the arteries become calcified and they become stiffer. Okay, and then we use this model to try to look at different antihypertensive, how they fared with this vascular stiffness, the calcification. So we did years of studies, and I will just highlight some of them. This one, for instance, what we did is we used two different approaches. One is to prevent calcification, and the other one is to regress. So once calcification is there, can we take it away? And this is what I'm showing here with daruxantan is an endothelin-1 receptor antagonist. They're not used as antihypertensives. At that time, they were under development. Irbesartan, of course, is a angiotensin-1 receptor antagonist, and hydrochlorothiazide, diuretic that we use commonly for hypertension. So what we can see is that after 4 weeks or 8 weeks of warfarin vitamin K, so this cocktail that we give to our rats to make them age faster in terms of their arteries, we have regression of the calcium content with the endothelin antagonist. We're about halfway there with the angiotensin-1 receptor antagonist and no effect of the diuretic. And of course, we had to speculate, how does endothelin antagonist can remove calcium? How can you remove calcium? One of them is to try to work with the pH. It's coming back to your presentation. So a more acidic pH would allow calcium to be dissolved. So maybe this is something like that is happening. So what we did, and there we have enzymes, carbonic anhydrase is one enzyme that can modify the pH. So we did the endothelin antagonist is this one. So you see the regression of calcification. But when we block carbonic anhydrase with acetazolamide, which is another type of diuretic, these carbonic anhydrase inhibitors, we don't have any more this regression, suggesting that this could go through a change of pH through carbonic anhydrase. So this was the first in vivo description of a mechanism to try to remove calcium from the arteries. We then looked at other possibilities, and here we looked at, it's funny how many similarities, but we said, okay, what's happening for the calcification to start? These elastic lamellae are broken down. They're broken down by what? So the matrix metalloproteases, the MMPs, are involved in breaking down the matrix, and they can break down elastic lamellae. So we said, okay, what happens, so this is, again, our model of warfarin vitamin K, and we see calcium deposition in the vasculature. And then we give doxycycline. Doxycycline can inhibit MMPs. Of course, we're in vivo. We can't use toxic drugs, and it's a bit more tricky. But we could use here doxycycline, and we showed that doxycycline, if we give it at the beginning, at the end, or in the middle, it also prevented calcification, suggesting that MMPs were involved into this process of degrading the extracellular matrix, allowing calcification to come, and stiffening our arteries. Then we went, this one was done ex vivo, so in cells. We had a model that we could actually induce calcification of the extracellular matrix in cell cultures. And we found that lactose, which is an inhibitor of the peptides that are broken down by MMPs, would not do anything. So it's not the peptide released by elastin that will produce calcification, but we could block it by a TGF-beta signaling inhibitor, this one, the SB compound. So this, we could show them that TGF-beta is somehow involved into the whole process. So to make a long story short, this was our working hypothesis, where we have aging of the arteries that we could accelerate with warfarin and vitamin K. We had early calcification, elastase transformation or degradation, fragmentation. This would lead to elastin peptides that we think are not so much involved, but also the activation of TGF-beta. And why we looked at TGF-beta? Because it's one of the major stimulants of endothelin production. So endothelin production in vascular smooth muscle cells could be triggered by TGF-beta, and then this would lead to changes in bone regulatory proteins that would appear, changing also in collagen. Endothelin is known as a fibrotic factor, and all these things could lead to vascular stiffness. So for us, endothelin was like, in our hypothesis and the grants we wrote, was at the center of our research, trying to find ways of dealing with vascular stiffness and trying to remove some of the calcium deposited in the arteries. Of course, endothelin is also a vasoconstrictor, and when arteries are contracted, they're not as flexible. They become more rigid functionally, not just structurally. So this is the main research that we did. And then at one point, we also branched into looking at, I told you that one of the risk factors of vascular stiffness is diabetes. And this study was done in 2003, and it caught my attention, saying that they said that patients with diabetes have, their arteries are 15 years older than patients without diabetes. So here they say that, for people that have chronological age of 61, their arteries look like they're 75. Okay, so diabetes accelerates vascular aging and vascular stiffness. Again, we ask ourselves, how does it do that? What's the process? What's happening? Okay, so we did some research into that. So we changed now. We had a model where we sometimes mix warfarin, vitamin K with diabetic, streptozotocin that can induce diabetes. And we looked at different markers trying to find what's happening. What's happening there? Is it related again to MGP and our capacity to blunt calcification or not? So we looked here at the carboxylated MGP. So that's the active form of MGP. And we found that when we treat rats with the diabetic regimen, they become diabetes, they have increased glucose for a period of time, there's less active MGP, suggesting that this would allow easier calcification of the matrix, okay? And what we found as well is that it's why there's less MGP, it's because the enzyme that makes MGP active, so the carboxylase that makes MGP active is downregulated. There's less when I have a diabetic environment. Okay, again, we kind of found a way by which our arteries become more susceptible to calcification and stiffness because they are less protected from our endogenous protector, MGP, which is less activated, okay? So there's less active form of MGP. The amount of MGP is the same, but most is inactive, not carboxylated. So we looked at, here is the same, so we looked then, again, upstream, what can lead to that? And we know that in, of course, diabetes, we have glucose, and we have advanced glycation end products, age, not to confuse with aging. So age bind to receptors. We have age-rage interactions, and this will lead to some cellular events. And we blocked both the formation of age within the extracellular matrix into the vascular wall, or we tried to remove them with a drug that was in development called alagebrium, was from France. So we worked with the company to try to test their product within our models. And basically we could show that the amount of age measured in the tissue, not circulating, but the ones that were formed into the extracellular matrix, was reduced both by pyridoxamine, which is preventing age formation, and alagebrium, which was removing the age in the matrix. And we found that this was associated with a reduced calcification of the arteries, suggesting that the age is important as a initial factor to trigger maybe a change in the expression of the carboxylase that would then reduce our defense and increase the calcification. And then we looked at the different age-rage interactions, and we showed that this was a cellular-mediated effect and not just a matrix-mediated effect by different, again, in vivo or ex vivo experiments. And this is a paper that was quite recent, and it's interesting that in diabetic patients, they looked at the activation of MGP, and they found that the under carboxylated MGP, so the inactive form of MGP, was associated with increase in stiffness, so pulse wave velocity, as you can see here, in type 2 diabetic patients. So what we found in animals, actually they found in humans, maybe 7 or 8 years later, so suggesting that deficient vitamin K dependent activation of MGP may lead to large artery stiffening and could be targeted with vitamin K supplements. So it's interesting that what we found and what was, something that was not known at the time seems to be relevant for humans as well. And now this will bring me to my last part of the presentation. What can we do about it? So now we already have a kind of a hint. Vitamin K, let's see. So coming back to the risk factors. So there are risk factors that we know can lead to vascular stiffness, calcification. We talked about them at the beginning: aging, being male, hypertension, diabetes. CKD is a very important risk factor because the phosphate and calcium are not balanced anymore, and calcification is much higher, and sometimes even affecting other arteries than the large arteries. We'll talk about that later. Dyslipidemia and smoking, maybe not as, and then we have stress signals for the vasculature: inflammation, we talked about it, oxidative stress, shear stress, so the forces applied on the vessel, advanced glycation end products, so age, increased calcium phosphate product, especially in CKD, high angiotensin II, ECM degradation, we all talked about that, and vitamin K deficiency or vitamin K antagonism, let's say, for instance, by warfarin. So these are the risk factors that we could address to try to limit the amount of vascular stiffening and calcification that will happen anyway. We can delay, like what we do in CKD. We can't bring the nephrons back if they're dead, but we can limit how many nephrons are dying by limiting the progression of CKD. It's a bit the same here. So if we address those risk factors, we treat hypertension properly, we treat diabetes properly, we stop smoking, we change sex, that's a joke. We can all influence how fast our arteries will age. Okay, and then there are some other interventions that I'll be discussing. So one of the issue, especially in patients with CKD, use vitamin K antagonists like warfarin less often. We now have other anticoagulants that could be favored in patients where there's more susceptibility to have increased vascular calcification, like in diabetes, for instance. So there seems to be a higher risk in patients with CKD or diabetes who are more likely to develop vascular calcification when we give vitamin K antagonists. It doesn't mean we have to stop them, but we have to think about the patient, let's say, profile and determine if this is a situation where I should avoid them or not. So again, this is something we can do. Vitamin K comes in different forms. K1 is phylloquinone, K2 is menaquinone, and this is a review done by a Dutch group that has been working a lot on vitamin K and all these issues in vascular calcification, and they show that vitamin A has no effect. If not, it will help progress vascular calcification. B, C, D, E, nothing. K1 and K2 seem to be working. Calcium supplementation, no effect. Phosphate retention, no data. Magnesium supplementation, possibly less progression. So we have a couple of, and aged garlic extracts. I don't know where this comes from. But anyway, we'll focus now on vitamin K and magnesium and what are the evidence. This is a study that was done in the Netherlands, and they looked at postmenopause women, and they did 3 years of vitamin K administration in these patients, and they saw that after 3 years, the stiffness index, so the lower the better, decreased quite significantly, and also the pulse wave velocity, so the speed at which this wave travels, again, the lower the better, was also reduced after three years. So basically suggesting that vitamin K2 supplementation could help get our arteries become more elastic, less stiff with time. Okay, so this is one of the strongest evidence for the use of, and this was double-blind, randomized, so it's a good study. It's not just in 5 patients. It's something that was quite a good publication. So this is one thing we could do. Another one would be choose which hypertensives we use, especially in older patients or before they become too old where calcification will take place. So basically this is a study from us showing that after, when we use a calcium channel blocker in the same model of warfarin vitamin K, we could prevent and regress the amount of vascular calcification by using a calcium channel blocker. And this has been shown as well in humans, and this is a study over 3 years, again, using a mix of a diuretic and a calcium channel blocker, or a calcium channel blocker alone. And you see that the progression of the total calcium score in the arteries, this is non-invasive, these are not rats, was actually coming up much more slowly than in patients treated with the other regimen, suggesting that we can limit or slow down the progression of stiffening and calcification by using the appropriate antihypertensives. So this is true for calcium channel blockers. We also have evidence that renin-angiotensin system inhibitors, so ARBs or ACE inhibitors, can also have a positive effect. This is a study where they gave either a ACE inhibitor or an ARB, and they saw that after 8 weeks, there was a reduction in the central systolic blood pressure, which is a kind of measurement of stiffness, although it's not just structural, it's very indirect measurement. Then they kept the same drug for another 8 weeks, and you see that there's no more beneficial effect. And then they added on top, if you took the ACE inhibitor, then you got the ARB on top. If you took the ARB, you got the ACE inhibitor on top. And they saw a further reduction of the central systolic blood pressure. We don't recommend combining these drugs, but it shows that the inhibitors of the renin-angiotensin system can also have an effect on stiffness of arteries, so they could be a good choice, especially in diabetic patients where we know it also protects the kidneys. So this is a study for use of magnesium. So we think of magnesium, what type of effect it will have. So the effect seems to be on the phosphate influence on cells. So it's not just working outside the cells, but actually modulating how cells work. This is the study they did is they cultivated cells and they looked at calcium content. This is with normal phosphate and normal magnesium. Nothing happens. They increase phosphate in the culture medium and they see this increase in calcium deposition, okay, in the matrix around the cells. When you go from 0.9 to 3.8, and when magnesium is normal, this is a high phosphate, let's say, culture medium, you get this increase in calcium. And the more you increase magnesium, the less you get this amplification of calcification. So basically suggesting that magnesium could be something that could limit the calcification of arteries. And some studies have been done in patients undergoing dialysis where you can play with the electrolytes into their dialysis medium, and they showed that increasing magnesium in there, they would reduce the amount of vascular stiffness, suggesting that it could have an effect. So the calcification was reduced. Another type of drug, again, I talked about the link between bones and arteries, which are normally the opposite. When bones are happy, arteries are also happy, but when we get calcification in arteries, most of the time we can get osteoporosis in the bones because the things are a bit linked. So they looked at the effect of biphosphonates, and this study is with denosumab, which is not theoretically a biphosphonate, but they look at the aortic arch calcification. I showed you in the image of the rat that it's an area where there's a lot of calcification. And they saw that for the control group at baseline, they had 29% of the area was calcified in their patients before starting denosumab. And after, I think it's a period of 1 year, it went to 46%. So progression of calcification. And it was a short time frame. I was surprised to see the results. Here they did the same, but with denosumab, instead of going to 43, it went down to 12, suggesting that it could enhance bone calcification and reduce vascular calcification. And then when they look a year further in these same patients, it was to 22, so still lower than initially, but progressing slower than in the other patients that did not receive the drug. And lastly, there is now a phase 3 trial with a compound called SNF472, which is a little bit like MGP. It blocks hydroxyapatite, let's say, buildup. Okay, so it will bind to hydroxyapatite and stop it from, because hydroxyapatite starts from a nucleation and then it evolves. So it sticks to it and blocks its proliferation, if you want, although it's not cells. But so this first graph here, graph A, shows that the more you give this SNF472, the less calcification or hydroxyapatite crystal formation you will have. So it blocks the formation of hydroxyapatite. So it acts a bit like a synthetic MGP. And here is, this one is in vascular smooth muscle cells. Same here, when you don't give the drug, but you give the conditions that will create calcium deposition, you have this response. Then you give increasing doses or in micromolar of this compound, and you get also reduction, very significant reduction of calcification of the matrix in culture cells. So very promising drug. The study now, the study design, the patients will receive either, it's randomized, so either the drug or placebo, and then they will be, after 12 weeks, all switched to the active drug, and then we will see what, so they stopped recruiting patients now. We're awaiting results. We don't know if this will work or not, but it's interesting to see. But again, like many drug development now, they did that in very niche type of situation where patients with chronic kidney disease will get calcification of smaller arteries. This is called calciphylaxis. And it's quite advanced. So I'm not sure it will be very effective because it's really advanced, but we'll see. We'll see how it goes, and we'll see the results at one point. And I guess if it's positive in there, then they can move to more longer term studies, because doing that in isolated systolic hypertension will take years, will take hundreds, thousands of patients, will cost millions of dollars. So I think they're starting with a smaller subgroup like that. So the other thing we can do to continue is continue doing research, continue to talk about it. So this is a very recent review in JACC, which is a very prominent journal in cardiology, but mainly for clinicians. So it's nice that they talk about it there, the importance of what we call medial arterial calcification in these larger arteries and how it impacts our system and what we can do about them. So in conclusion, I hope I convince you that large arteries are not inert pipes. We always think that they're just there to allow the blood to go through and that's it. No, they have a function. They have an important function of buffering this systolic wave of pressure. And what we know now is that more than that, they are becoming integrators of our cardiovascular health. Okay, so if we have bad health, hypertension, diabetes, obesity, they become sick as well. So their stiffness is a measurement of our cardiovascular health, and it's easy to measure. So it's something that maybe one day we'll go with blood pressure measurement. We will measure stiffness as a measure of how healthy you are in terms of cardiovascular system. Isolated systolic hypertension is difficult to control. The systolic is never going down enough, and then we bring the diastolic so low that our patients are feeling dizzy and feeling completely exhausted because we're using the wrong medicines. We're using medicines developed to decrease diastolic blood pressure, and we hope that it will work on systolic pressure, but it's two different mechanisms. It's not just vasoconstriction. So I hope I showed you also that vascular calcification is a complex process with several molecular events that could be targeted. Again, we are just starting to work on that. The different therapeutic avenues that are being explored, like vitamin K, magnesium, using the proper antihypertensives, maybe biphosphonates, SNF 472, are all things coming hopefully to help our patients, delay their aging of the large arteries and hopefully keep them healthy for even longer. Thank you very much.
Thank you, Professor Moreau, for a wonderful talk and enlightening us about the role of matrix GLA protein on vascular calcification and arterial stiffness and their effects on cardiovascular disease and aging and mortality, and ways and strategies to probably combat it. Our next speaker is a regional speaker. He's coming from United Arab Emirates, from Khalifa University. His name is Professor Abdu Adam. And Professor Adam has obtained his PhD from Uppsala University from Sweden in 1987. And after that, he completed postdoctoral training at both the Pastoral Institute in France, and then he got a postdoctoral position at the Karolinska Institute in Sweden, where he then stayed and attained an assistant professor position, and then an associate professor position in 1994. He then moved to United Arab Emirates, where he progressed to become a full professor at Khalifa University, and there obviously he developed his research, and he contributed to over 247 publications in prestigious journals. He has an H index of 50, and he has obtained several patents in the area of anti-cancer drugs, as well as several patents for anti-diabetic drugs as well. Please welcome me to join Professor Adam to the podium, where today he'll be giving us a talk on withania coagulans, improving insulin sensitivity by attenuating RAGE NF-kappa pathway. Thank you.
Good morning, everybody. Sorry I'm a little bit late. I also changed a little bit the title of my talk to incorporate the previous title and also a little bit more. I thought to just invite you to see our recent data, which is not yet published. I'm going to talk about novel insights in the anti-diabetic mechanisms of withania coagulans and its active constituent compound X. You might be wondering, compound X. This is a new compound which we are trying to patent. It's in the American Patent Office. Hopefully it might be patented or not. Let's see. Thank you for the introduction, nice introduction. I appreciate that. So I'm just going to reiterate that some definitions, which I'm sure most of you know, just a little bit different explanations or definitions. Back in the 1999, the WHO and the American Diabetes Association defined diabetes mellitus they described diabetes mellitus as a metabolic disorder of multiple etiology, which is characterized by chronic hyperglycemia with disturbance of carbohydrates, fat, protein, and so on, from defects in insulin secretion, insulin action, or both. Later on, back in 2006, there were several things added into that definition. Primarily, basically the same, but is a condition primarily defined by the level of hyperglycemia, which gives rise to risk of microvascular damage, retinopathy, nephropathy, neuropathy, also associated with reduced life expectancy, and microvascular and macrovascular complications. Why I'm trying to put that is because it seems that we don't understand the biology of diabetes 100% yet. And that's why the medications we have today in the market are really not to target. I mean, you don't treat diabetes as it is. You'll take your medications possibly until you die or you have some complications. So the prevalence of diabetes, according to the IDF, the International Diabetes Federation, is that there are about 536.6 million people with diabetes worldwide in 2021. By now, definitely more than that. It is one of the top 10 causes of death. Also, the global healthcare expenditure is very high, around almost $1,000 billion US. The number of people with diabetes is predicted to rise to 578 million by 2030, and most probably to almost 800 million by 2045. This indicates that, excuse me, what's going on? According to the IDF, diabetes can be considered an emerging epidemic. So if you see something that's growing so fast, it must be some sort of an epidemic. And in the last 10 years, more than 62%, it has been increasing by almost 62% worldwide. So basically, it's an extremely important disease, which is practically form of an epidemic, which we really need to look at very carefully. There are two types of diabetes mellitus, as you very well know. The type 1, which is absolute insulin deficiency. This constitutes about 10% of diabetics in the world. Autoimmune, 85 to 90%. You can find autoantibodies causing insulites, leading to beta cell destruction. Treatment is through insulin. Type 2, on the other hand, which constitutes almost about 90% of people with diabetes. This one is an insulin resistance. Basically, there is inflammation or autoinflammation, and there are several pathogenic mechanisms. It could be glucotoxicity, lipotoxicity, oxidative stress, general inflammation, amyloid deposition, and so on. And the treatment we have today is starting with diet, exercise, and different kind of oral hypoglycemics until one reaches the stage to get insulin. In this case, the pancreas produces insulin, but the tissue, the cells, they fail to sensitize to insulin. Insulin has a lot of, the hormone has several functions, which I'm not going to go into, but if we look at the mechanism of insulin secretion, and insulin sensitivity is extremely important. This is a beta cell which can be activated through insulin or through glucose to release insulin. Once insulin is released into the bloodstream, then we have insulin receptor. The insulin receptor is heterotetramer, consists of 4 units, 2 alpha and 2 beta, and when insulin binds to its receptor. So these detailed cascades are extremely important, maybe in trying to find a treatment or some sort of therapy. I will just go through them extremely quickly because it's, just one part of them would need a whole lecture to go through the details. But if we just summarize that once insulin binds to the receptor, then it will be a conformational change. As you know, that conformational change will cause, there will be a phosphorylation of the receptor. That phosphorylation will lead into phosphorylation of other parts in the receptor, like the insulin receptor substrate 1, and many other proteins will also be phosphorylated. The IRS1 is a very important molecule which propagates the insulin response and then will try to activate other molecules downstream so that the insulin response will be propagated through the system. It will activate the phosphoinositide 3 kinase, which in turn will activate the phosphoinositide dependent kinase 1, which is very important. Also, I'm just selecting a few of them. And then we have AKT, or protein kinase B also, as is known. And this activation of phosphorylation activation of AKT will phosphorylate an important molecule, which is AS160, this is 160 Dalton protein. Activation of phosphorylation of this protein is extremely important because it is important in the translocation of GLUT4, which is an important glucose transport protein. And this will be transported to the different membranes where, for example, it could be a muscle, it could be a liver, or any cell which has insulin receptors, and then glucose will easily go through into the system or into the cells and so on. So this is in a normal person who's not diabetic. This is a cascade of what's happening, and you can interfere at any stage. In diabetes, this flow doesn't happen because, first of all, in type 2 specifically, we have a desensitization, or there is a receptor sensitivity doesn't exist or extremely low. And if insulin doesn't activate its receptor, we will not go through all this cascade. So what are the mechanisms then of insulin resistance? And if you can see here, it's exactly the opposite of what I just mentioned. It will be a decreased IRS tyrosine phosphorylation. It will be a decreased PI3 kinase, which I mentioned, decreased AKT activity, decreased AS160 phosphorylation. So this will lead to decreased GLUT4 to be translocated to the membrane so that it can allow glucose to get into the system. So this reduced or decreased GLUT4 translocation will cause reduced insulin-stimulated glucose transport, because the glucose transport we are talking about now is stimulated by insulin. So if insulin binds to its receptor, the cascade happens, glucose will get into the tissues. So this will be then not happening. It will be reduced stimulated reduced insulin-stimulated glucose transport. This will cause insulin resistance, what we know as insulin resistance. This will cause hyperglycemia, and the hyperglycemia will cause glucose, which is floating in the blood, to bind to different proteins, lipids, nucleic acids, and this causes something called advanced glycation end products. And these are dangerous end products which will cause death of the islets and several other things. And to my surprise, I mean, when you read in the literature, there isn't much digging into these mechanisms, and try to find. Maybe this could be a very important way of trying to get some sort of therapy which is different than what we have today. So so this persistent hyperglycemic state in type 2 diabetes, specifically millets, leads to initiation and progression of non-enzymatic glycations, which I just mentioned here as advanced glycation end products. So we get these advanced glycation end products, and these advanced glycation end products will permanently modify the structure of proteins, plasma lipoproteins, cells, and so on. And also they can induce formation of aggregated proteins, which will cause toxicity and will maybe kill the islets in the pancreas, among other things. I'm not going to go through this. These are the different ways that happen in a diabetic person, how these advanced glycation end products can be produced by through lipid peroxidation. Maillard reaction is one of the main, Wolff pathway, Hodge pathway. So it's a whole set of things which one really needs to look into very carefully. So if we try to summarize the engagement of this advanced glycation end products with its chief receptor is called RAGE, receptor for advanced glycation end products. This is the main receptor for it, but the advanced glycation end products can also bind to other things. But their main receptor is called RAGE, and when they bind to this one, they activate a myriad of signaling pathways, including the TGF-beta, NF-kappa B, which we're supposed to talk about, leading to enhanced oxidative stress and inflammation. So by doing this, it's increasing oxidative stress and inflammation, and these are two main culprits in diabetes. One can say diabetes maybe is a chronic inflammation in different tissues in the body. Downstream from this age-RAGE axis, you can find compromised insulin signaling, what we discussed earlier. You don't find all those activations and so on, so you won't have any glucose to get into the tissues. So you can also get RAGE-induced pancreatic beta cell toxicity, which means will kill the beta cells, activation of NF-kappa B, which is prolonged induction of tissue-specific inflammation, and this can cause even apoptotic mediators and apoptosis. The skeletal muscle, as you know, is one of the major players in taking glucose in the body, is the largest insulin-sensitive organ in the body, for almost accounts for 85% of whole body glucose uptake and utilization. So our skeletal muscle is extremely important. So it's, it's pertinent to study the skeletal muscle in diabetes and to see what happens with it. Also, the intracellular signaling cascades, which are activated by age, RAGE, NF-kappa B axis, these ones will concur with muscle damage, altered muscle metabolism, and myopathies. And all these are characterized by chronic inflammation and also increased production of reactive oxygen, which is oxidative stress. So our aim was to try to look into and dissect these different mechanisms which are involved in the cascade, which I just mentioned to you, to see where do we see a problem. The thinking we have today is, as that after diet, advice, and exercise, most probably people start them, the doctors start you on metformin, then maybe they will add after, other pioglitazone, sulfonylureas, and so on. There are different ones, what we have today. This is what I put here, what we have today in the market. But if you look at them, like these are insulin sensitizers. Here we have insulin secretagogues. We have drugs like reduce carbohydrate absorption, like the glucosidase inhibitors. We have the ones which mimic and prolong the action of incretin hormones. We have also drugs which help to eliminate blood glucose through urine and so on. And finally, we have insulin, which is the main drug, at the end of the day. Of course, treatment-wise, you start with a monotherapy, and if it doesn't work, your A1C, it does not go down after a few months, then they will give you another drug to that, and then they will give you a third drug, and maybe when you reach a fourth or so on, you possibly go into injections, whether insulin or some of the new injections which we have nowadays. So this is where we are today. And this is not helping in any way. So what do we need to do? What is the next step? Should we go and see discovery, development of novel anti-diabetic drugs? We have talked about insulin secretagogues, which we have them already. We have insulin sensitizers. We don't have anything that deals with age, range, NF-kappa B axis. Our thinking, just to start straight, is that we don't think diabetes can be treated by a single function or by a single activity. Like only insulin secretagogues cannot do that. Neither can insulin sensitizers can do that. And I don't believe that this age range NF-kappa B would do that either. But we have to think that a drug which can have a polypharmacological effects at the same time with minimum side effects. Because always we know from pharmacology that if a drug has several effects, then the side effects will rise same time. That's what we have been told, and that's what we teach. But we should think, looking into different mechanisms, how we can find drugs which can have a polypharmacological effect with minimal side effects. That's our start point. I'm sorry, my throat is so dry, sick. So we started to look, they are different. We look at both at synthetic sources, chemical synthesis. We also looked at medicinal plants. And today also there are other ways of doing through recombinant DNA technology. You can do it also through different things, which I don't want to go through. But we chose a plant which is called Withania coagulans. It's a very well known in the Indian subcontinent, has been used for different things for the last century. The berries contain milk coagulating enzyme. They contain esterases, fatty oils, essential oils, alkaloids, a lot of things, withanolides and coagulins. Also, it's considered anti-inflammatory, anti-tumor, hepatoprotective, and so. So I'm just trying to summarize the literature that Withania has been used for. Also, the chemistry of Withania coagulans has been very well studied in Pakistan. It's been isolated around 40 pure compounds from this plant. But there isn't much work done with those compounds. We have chosen one of them after a lot of work, and that's what our compound X. So we have worked with Withania for several years. We have published it earlier to show that Withania is extremely important. We have used 4 months old streptozotocin-induced diabetic rats and followed them by treating them with Withania coagulants. We give them oral gavage. Our results show that Withania coagulants reduces the occurrence of oxidative stress and inflammation. Those are 2 main culprits which I showed you on this age range thing, plus in addition other things also. So it's once we found that it's an extremely important in trying to reduce inflammation and oxidative stress, and by doing so, it improves the hyperglycemia in these animals. Then we thought to look into it more broadly, and our aims and objectives were to find its effect on the pancreas. What does withania coagulants do on the muscle? As I told you, is a very major component of glucose users in the body, and also to investigate the effect of withania coagulants in human type 2 diabetic skeletal muscle myoblasts. We want to see at the basic mechanisms what happens at the myoblast level. So we started with animals, with the rats, where we inject them with streptozotocin, which destroys the islets. And then we leave these animals for 8 months. I mean, 8 months is a long time. You know, of course, you cannot do these studies in Europe and so on because you will be bankrupt. All your money will go for paying for the hotel of the rats. But luckily, in the UAE, we don't pay for animals, so it's a cheap thing. So we leave them for 8 months, and then after 8 months, we take the animals and divide them into 4 groups with a non-diabetic control, non-diabetic withania coagulants treated. We want to see if the coagulants withania can have effect on a normal rat. Then we have the diabetic control, the ones which are diabetic, and the diabetic. And the diabetic withania coagulants treated. So we have diabetic rats, and we have diabetic rats which are treated with withania. We treat them for 40 days, which means that these animals will be 9 months diabetic, which is a long time in the life of humans. It could be more than 30, 40 years diabetic patients. Finally, we collect their blood, we look at their muscle, pancreas, everything that can be collected to look at it. Our methods are, we just look at blood to see different markers. We look at the pancreas, look also for different markers like age, rage, oxidative stress, inflammation markers in the pancreas. We look at in the blood also to see how insulin, fasting glucose levels, insulin, postprandial glucose, insulin tolerance, and so on. We see the muscle for markers for insulin signal transduction like IGF-1, IRS-1, GLUT4. We look for markers for age range, NF-kappa B axis, the ones I mentioned earlier. We also try to see markers for oxidative stress and try to see for inflammation and oxidative stress. We try to take up 7 to 8 rats so that there is no doubt the results, and we repeat our data at least, or study at least 3-4 times before we try to publish. Let's see then the aim one, which is the effect of withania coagulants on the pancreas of STZ-induced chronic diabetic rats, because we want to see what is it doing. It's improving the situation of these rats. We see these rats become active, they are better, they are not like going down, so after 8 months of being diabetic. If you look at the fasting blood glucose, so the 2 columns you need to concentrate on are the one with diabetic control and the one which is treated. These are just normal rats, normal controls, and normal control which is treated with withania. The fasting blood glucose drops down significantly compared to the control, and although it does not come to 100% to the normal rats, but still it's significantly different from the diabetic one. Insulin is increased significantly, almost to the normal levels compared to the diabetic controls. We have glucagon also, which is another player in diabetes. Also, in the diabetic rat is significantly increased, but withania treatment will reduce it significantly. The age advanced glycation end products in the blood, you will find that they are very high in the diabetic controls, whereas they are significantly almost come back to normal in the diabetic withania treated. So we look at the pancreas also in this group. So the pancreas in this group, the age in the pancreas is significantly affected or attenuated compared to the diabetic control. We have also the rage, the receptor for the age is also significantly attenuated here. And also the islet amyloid polypeptide, which is an extremely important in diabetes. It's aggregated, but people, they don't know what is it doing there. I would appreciate if anybody can tell me what it does, but I tried to find the literature, but nobody says what is its role exactly but it's one very important. In Alzheimer's disease, amyloid is extremely important. In diabetes, amyloid is not that important, or it's not. So that would be also one thing to look at. This compound brings back the islet amyloid polypeptide to normal levels, which is very interesting, of course. We looked at oxidative stress. GSH, the glutathione, is totally lost in the diabetic rats, but if you treat them with withania, their glutathione levels will come back, and therefore they will become less affected by oxidative stress. If we look at MDA, this lipid peroxidation, MDA is a malondialdehyde. This is a marker for oxidative stress, and you can see the diabetic rats that really they are affected by oxidative stress, whereas if you treat them with withania, the MDA levels significantly come back almost to normal levels. Another is C protein, which also is an indication of inflammation. It's very high in diabetic rats, whereas it comes to normal levels here. Nitric oxide, also another marker for inflammation. Also, as you can see, it's a problem. So this compound, of course, when we say withania, it contains a lot of compounds in it. As I said, at least 40, 50 different compounds. But still, somehow, is having a poly effect. It has effect on oxidative stress, it has effect on inflammation, it has an effect on the advanced glycation end products. The problem is we have to see, because it's used as an additive in several foods, is also used by different people. The story, how we started with this, I have a colleague who's a diabetologist, and he was giving these patients drugs so that they can use them. They come back, they never take the drugs. But they drink every morning a cup of withania. They put the berries in a cup of water, they drink it in the morning, and that's it. And their diabetes was fantastic. And the guy came running to me crazy and said, Abdul, please do something. I have a problem. I said, what? These patients are not following the rules, they are not taking their drugs, and so on, but still their glucose level, everything is fine. Their A1C, everything is perfect. That's how we started with the whole project. So withania in itself is being used a lot in the Indian subcontinent for different things. Okay, so it's directly, it's not so toxic to kill a person. So the conclusion from this first study is that withania coagulants has the potential to reacquire normal glycemia through attenuation of the age-mediated oxidative stress. Also, this study supports the hypothesis and provides evidence that age, which is advanced glycation end products, detoxification, rage inhibition with emphasis on antioxidant defense has a protective effect on the pancreatic islet damage and beta cells. I'm not showing you here a picture of the islets. We take the islets and we try to see the islet number of islets by immunohistochemistry. I should have maybe put a picture. And when in the beginning of these rats, before we treat them, there's almost nothing islets there. But after treatment with this, you will find almost control levels of islets. So the drug or this compound somehow brings back the islets which were dead to life. Maybe new ones are created, or I don't know if the old ones are coming back as they were. But anyway, that is a finding from this study. The second aim of the study was to try to see withania coagulants on gastrocnemius muscle insulin resistance. I'm just giving you this one, but we have done now results which are not out yet, but we know that compound X does exactly the same thing what I'll show you now. Okay? So we want to see now in the muscle, insulin resistance, how it can be dealt with. We know in these animals there is huge insulin resistance in them. So we want to see after treatment with Withania, what would happen. The problem is with the compound X, we have very small amount of it. We just managed to get a lot of it, and we have done repeated these experiments, and they are exactly the same. So the blood glucose after treatment in this muscle is that we have the diabetic controls, which is this one you can see here. A lot of glucose in their blood, whereas when you treat them with Withania coagulants, it comes down almost to the control levels. We have done insulin sensitivity for this, and the area under the curve shows you that when they are treated, they come back to normal. We have also checked the postprandial glucose, and you can see in day 0 and then day 40 for the diabetic rats, nothing changed. Whereas for the diabetic, after treatment, the level of glucose postprandial level would come down significantly, although it doesn't come to the control levels. This is just to show you how we did the insulin thing. So if we try to summarize here what we are doing, is that the hyperglycemia, so the hyperglycemia, what it's doing is always it increases the age, the glycated end products. Also it increases oxidative stress. This will, of course, cause rage. Binding of these things will cause activation of NF-kappa B set. The oxidative stress will cause stress in the endoplasmic reticulum, which also will activate the NF-kappa B pathway. We have very high inflammatory cytokines, or increase in number, IRS1, serine phosphorylation, and a decrease in GLUT4, which gives us insulin resistance. At the same time, there are others who work against this system. D-dosed sirtuin-1 and AMPK, these are group of proteins which destroy the advanced glycation end products in a normal person, which they are inactivated or they are so low decreased in the case of diabetes. So our research is we want to see, can we boost these ones so that we close the rage, and by doing so, age, even if there are advanced glycation end products, they will never do anything. So this cascade will not come. So, and also a substance that can also inhibit the oxidative stress. Most probably will be a drug that will reduce insulin resistance. So based on that, we looked at the effect of Withania coagulants on age, and we can find very easily that it reduces significantly, similarly with rage. So we looked at D-dosed and sirtuin-1. In the diabetic rats, D-dose is significantly reduced. So it means those compounds, those proteins which inhibit the insulin resistance are inhibited in the diabetic rat, whereas after Withania, they come to normal, and that's most probably why we don't see any insulin resistance after treatment with Withania. Similarly for sirtuin-1, we see the same thing, that after Withania, the sirtuin-1 levels are increased in these animals. We looked at the NF-kappa B, which is a main culprit pathway. NF-kappa B in itself, it has two nuclear fractions, P105 and P65. And as you can see here, especially the P65 is the one which is increased in the case of diabetes, whereas the P65, although it's increased, is very minimal compared to the And both of them are significantly reduced by withania coagulants. GLUT4, which is the final thing, the final protein which is going to go to the membranes and allow the glucose to come in, is significantly reduced. So the GLUT4 pathway somehow is blocked during diabetes, as I mentioned earlier. And whereas GLUT1, this is another protein which is not involved in diabetes, is not affected at all by withania. So it's selective for certain kind of thing, which is a pathway which is in after insulin sensitization, insulin binding and all the cascade that gives you insulin sensitivity. GLUT4 is involved there, whereas GLUT1, which has no role at all in diabetes, is not affected by withania. Similarly, oxidative stress, this is significantly affected, back to normal almost, but not 100% to the control levels. And the MD malondialdehyde is significantly increased in this case, and whereas after withania is reduced to normal. Inflammation, we look at other markers of inflammation like TNF alpha, and you can significantly see TNF alpha is also, because always people ask, oh, okay, you saw that, why didn't you do TNF alpha, which is very important. We did TNF alpha, and we find that it's increased in diabetes, it's well known, whereas it's attenuated by withania coagulants. IL-10, which is not a pro-inflammatory cytokine, it's an anti-inflammatory. It's reduced in the diabetes rats, but it's increased after withania. So that is also a protective thing. So the withania is, as if by now, if you must have realized that it's not acting through one mechanism, but it's acting through different mechanisms in this case. We looked at IRS1, which is this insulin receptor substrate 1, which I told you in the beginning. When insulin binds to its receptor, phosphorylation happens for the insulin receptor. When insulin receptor is phosphorylated, one of the first proteins that is phosphorylated is IRS1, the insulin receptor substrate, and this one will propagate the effect of insulin down the line, so that we get everything until we have glucose getting into the cells. So IRS1, after withania coagulants, comes back to normal. It's not different from the normal statistically, whereas in the diabetic rats, the IRS1 is reduced so that it doesn't have any function. We look at IGF-1. IGF-1 is similar, insulin growth factor 1 is similar to insulin. Most probably, insulin uses sometimes IGF-1 receptors, and IGF-1 might use insulin receptors, so they interact. But also, insulin growth factor 1 is very low in the case of the diabetic controls and is increased or boosted by withania coagulants. Because all these are major players, insulin-like growth factor 1 also in diabetes has a role. We don't know either through the insulin receptor or through other mechanisms. So if we summarize then, insulin resistance causes hyperglycemia, which leads into age-range increase signaling, blocking the host defense sirtuin-1 and D-dosed, which reduce this age-range effect. We have also increase in oxidative stress, and this will lead to the NF-kappa B pathway, which is increased inflammation, and cytokines which are inflammatory and so on, ER stress, and so on and so forth. And withania coagulants will do is that it will inhibit all this cascade at different levels. So in conclusion, from this study, we improve glycemic status in these animals. We attenuate age-range NF-kappa B axis. We suppress inflammatory cytokines and oxidative stress. I could have added here, we increase, anti-inflammatory cytokines levels, upregulate the depleted host defense, like sirtuin-1, and so which are very important in this case. And finally, the administration of these withania coagulants represses the expression of age and rage, downregulates NF-kappa B hyperactivation, and upregulates the depleted host defense system, DDoS and sirtuin. So these are different mechanisms that happen at different places and different times. The results obtained in this study reveal that withania coagulants as a therapeutic strategy to ameliorate age rage-induced insulin resistance and GLUT4 expression in skeletal muscle of chronic diabetic rats. So from this, we can also say that withania coagulants has insulin sensitizing activity as a final conclusion after all that, okay? Aim 3, which is the final one, I hope I will still have some time, to investigate the effect of withania coagulants, compound X, on human type 2 diabetic skeleton. We did this studies is because we don't need very much for the cell culture, but now today, I don't have the data with me, but we have done animal studies on compound X, and we see exactly what I have told you just now. And that's what we are trying to patent. So we want to investigate the effect of withania coagulants and compound X on human type 2 diabetic skeletal muscle. This is taken from a patient, a diabetic patient, who's around 68 years, Caucasian, and has diabetes for a long time, almost 20 years. So with the cells, the myoblasts, we split, we're seeded, leave them for 48 hours treatment, and then we did LDH, MTT, this is just cell viability and so on and so forth. And then we studied, the most important is that we studied the myogenin, atrogene, and MyoD1, which are very important for in diabetes, as we'll see in a minute. We allowed them to differentiate for 7 days in media, and on day 8, we do the treatment with withania or compound X. So we have tried also, we checked several others as standard, metformin, insulin, glibenclamide, pioglitazone, because these are the standard medications we have. We just want to see how do they fare in this competition. This is in the LDH release. You can see most of them have some effect. For the MTT also, we can see that there is no significant difference between them. So some of them have slight difference from controls, but basically there's nothing to write about. The most important is the effect on the myogenin, myogenic regulatory factor in the muscle. And you can see here, you can see this blue dots, this is in the control. If you treat them with insulin, with metformin, and with anticoagulants and coagulansin A. So all of them, as you can see, if you measure this, you will find insulin as a higher, and then followed by coagulansin, withania coagulants, and compound X, which have also higher, whereas metformin doesn't do anything to that, doesn't increase. So that shows you metformin doesn't have any effect on this. So that's where this polypharmacological effect comes in. And that's why metformin cannot help in everything. We have looked at another myogenic regulatory factor. It's atrogene 1. And as you can see here, all the compounds have some effect on the atrogene, insulin, metformin, withania coagulants, and compound X. But then when we look at the MyoD positive cells, here we can see that pioglitazone has significant lower effect, so it doesn't have any effect, whereas insulin fares very well with withania coagulants, compound X, and also with glibenclamide. We looked at finally at GLUT4, and we can see GLUT4, metformin, when you treat the cells, the insulin has a positive effect, which increases GLUT4 in those cells, but neither metformin nor glibenclamide nor pioglitazone have any significant effect compared to controls. But withania-coagulants and compound X are the ones which compete with insulin on that. And even they show much higher significance compared to the metformin, glucosamine, and pioglitazone. For GLUT1, none of them, GLUT1 is not so important in diabetes, but none of them has any direct effect on GLUT1. So what I want to say as a conclusion here is that, withania-coagulants and compound X has the potential to significantly enhance the downregulated GLUT4 expression, which is extremely important in diabetes treatment. This enhances the insulin-stimulated glucose uptake, that you make a resistance back to normal. Positively regulate MYD, myogenin, while suppress atropine 1 in these cells. And our final general conclusion is, if you take all these things which I showed you, hopefully you are convinced with that, taken together our findings, they demonstrate that the withania-coagulants as a novel therapeutic strategy to preserve the functional pancreatic beta cells mass, and that's in the case of the beta cells, and subsequently improve skeletal muscle insulin sensitivity by attenuating the age-range NF-kappa B axis. However, we are open. Further research and a better understanding of the mechanism of action of withania-coagulants may demonstrate it as a breakthrough potential therapy for the management of type 2 diabetes. Thank you very much. And I'd like to thank my colleagues, Mariam, Nahid, and Nasruddin, who participate in this. Thank you very much.
Thank you again, Professor Abdu, for enlightening us about the role of withania-coagulants on improving insulin resistance and sensitivity, and pancreatic beta cell function, and its role in diabetes and a potential therapeutic agent. We've had 3 sessions on cancer, cardiovascular, and diabetes that were all insightful and very helpful to us and resourceful. And I'd like to thank all the speakers for this session and conclude the first session. We can now all go to the next session, which is the poster viewing for the next hour until 1:30. Thank you all.
So good afternoon, everyone. Welcome to the second session of the Drug Discovery and Pharmacology. We have 2 exciting topics to be covered this afternoon. And our first speaker for this session is Professor Khalid Urabi. Professor Khalid obtained his B.Pharm degree from King Saud University in Saudi Arabia, and he received his PhD degree in pharmacognosy from University of Mississippi. He is currently a professor in the Department of Pharmaceutical Chemistry in the College of Pharmacy, Kuwait University. His research focuses on the discovery and characterization of novel bioactive compounds from medicinal plants, marine micro and macroorganisms. He's a member of several professional societies, including the American Society of Pharmacognosy. He had published over 48 peer-reviewed research articles in high-ranked journals, and he has an H-index of 17. He had supervised several PhD and master students, and he is heavily involved in research and teaching the undergraduate, graduate, and the PharmD program in pharmacy. Without any further ado, please join me in welcoming Professor Khalid Urabi.
Assalamu alaikum. Thank you, Dr. Fatima, for your nice introduction. I'm pleased to stand before you today or this afternoon to give you some, I would say like general overview about the importance of natural products, particularly herbs or plant in the drug discovery, and also the obstacles or the challenges that are faced in this field. So in this presentation, I'm going to cover some definitions. Maybe I will also cover some historical background about the development of natural products as herbal medicine and folkloric medicine or traditional medicine. Also, I will talk about natural products rules in the modern medicine. I'm going also to cover drug discovery and the role of the natural products in the drug discovery. Then I will be covering the main topic, which will be, or the main theme of this presentation, which will be the advantages and the drawbacks of natural products in the drug discovery. I'll be finishing with outlook of natural products after that, I mean the future, okay? Then I will conclude with a summary. All right, so if you look into herbal medicine, I will just expand it a little bit to say like natural products medicine, because herbs means plants. However, natural product means any natural thing, like maybe compounds or active compounds coming from plants, coming from microorganisms, either terrestrial or marine, as well as, of course, animals. So the definition of herbal medicine or natural product medicine, they are products from various natural sources. Here, we will be dealing with the plants mainly. So as an example, I'm giving Digitalis purpura. This is a plant from which digoxin and digitoxin are extracted and used as cardiotonic agents. So those might be like either the entire plant, like we have here the entire plant, I mean, that covers the aerial parts and the underground parts as well, or might be a special part of the plant. For example, digoxin is found to be concentrated in the leaves, so you might be dealing with only the leaves, leaving other parts aside, or it can be extract, for example, tincture, elixirs, or might be an exudate. So Digitalis purpura, we call it like Mother Nature. I mean, so that is very common, the elixir of the Digitalis purpura or the tincture of the Digitalis purpura. And it might also be only pure compound, a pure compound that is isolated and known to exert the action, for example, the digoxin, which is marketed. So anything over here is considered as natural product medicine or herbal, in this case, herbal medicine. So it's a more general term than just those fancy formulations we find them like in GNC. It's more than that. All right, so according to the WHO, they define the herbal medicines as part of a traditional medicine, which is the folkloric medicine, which is pertaining to societies or communities, isolated communities, used in the maintenance of health, prevention, diagnosis, or improvement or treatment of physical or mental illnesses. Of course, this is the WHO. For example, the FDA, they do have some regulations about herbal medications or herbal preparations, but the manufacturer should not claim that they treat any disease. I mean, they can say they improve the health status, they, for example, improve, for example, the cardiovascular system, status, but should not be mentioned like explicitly they treat this disease, all right? So this is the difference between the WHO definition and the FDA definition. But I'm not going to cover those differences. So according to the WHO, that might include herbs, like herbs in their, I would say, original status or in the raw stage, or herbal material preparations. So like, for example, this picture is from one of the apothecaries in Germany, and we know that Germany may be one of the most advanced countries in selling and regulating herbal medications, all right? So they do consider that as medications, all right? You go there with prescription, so the pharmacist over there will combine a few material from herbal material from here and there, and will give you the preparation. So that is a herbal material, or it can be, which contains an active ingredient, a plant or exudate, or combinations of both. And also it can be like finished formulations or finished products. And those products are, I would say those finished products are used worldwide. In some countries they are regulated, and in other countries they consider them as like food supplements. They call it like food supplements, like they will supply, for example, missing of certain vitamins or certain minerals. But in other countries they do consider them as medications, and there are like quite, I would say, strict regulations about that. So what is the share of herbal medication, the use of herbal medication, for example, worldwide? It is estimated that more than 80% of the population in the developing countries, they are using herbs for health and other purposes. In fact, sometimes they use it to treat diseases. That is not the only, I would say, statistics we have over here, but also in the developed countries like US and European Union, about more than 1/3 of the population over there, they use herbs for health purposes as well. But maybe it is regulated over here, like in the US, they don't use them to treat diseases, but rather to support the status or to support the health status. And actually it is a big industry. So it is estimated like the annual, I would say the annual income of this industry is about $7.5 to $8 billion annually, which is a big industry actually. I'm sorry. So those are the herbs, or the, I would say the raw herbs, or the preparations from the raw herbs. But what about the modern medicines? I mean the drugs, the pharmaceuticals. So more than 25% of modern medicines have natural active compounds, either directly, I mean natural products, or natural products hybrids, or natural products analogs, or semi-synthetic derivatives. So all of those, we consider them as natural products related medicine. All right, so now let us, fly back in history and see how natural products as medicines originated, or did originate. Of course, just imagine with me like all civilizations, like the Sumerian and Akkadians. And even before that, before the recorded history, people on earth, or mankind on earth, usually goes to nature or went to nature to provide him or them as a society with food. This is the first thing. Also shelters, like for example, the wood to build something. Of course, after using the caves, they kind of modernized. So they started to build houses or homes using wood. And then also for clothes, like cotton and linen. So they use them to textile, when the textile industry, so they started to go to nature or to the plants to have clothes. So it's not like, I would say, a big wonder, or it's not a surprise to go for nature again, for plants, to what? To treat diseases. So it started from there, all right? And that was like about the 3rd millennium BC. I'm talking about the recorded history, but definitely it goes, before that, of course. Then historically, we know the Hippocrates, or Hippocrate, the father of the medicine, that was a Greek physician, described the medicinal natural products from plants. He has records, or we have records of about 600 different plant species for medicinal purposes. And then came Bedouinus Dicraeus. Again, this is a Greek botanist. He is the author of the De Materia Medica, which is the most authoritative reference we have till now about medicinal herbs, historically. So he also reported the use of over 600 plants and the indications of those plants as well. Passed down the generation, the Materia Medica passed to other, I would say, influenced other civilizations like Arab and Muslims, and this is after the fall of Rome. For example, we have Avicenna and Rhasis, all right? And for example, in his well-known or famous book, Al-Qanun fi al-Tibb, Qanun in Medicine. And of course, there is Abu Bakr al-Razi, who has also written a book about medicine. It's called Al-Mansuri fi al-Tibb. So those are just two examples. I'm not going to elaborate more, but we have a lot. Apart from this place, I mean that geographical place, we have also other civilizations. For example, the old Egyptians, they do have also their folkloric medicine, Chinese, and also the Indian with the Ayurvedic medicine. All right, so I'm sorry for this glitches. This is because it was designed on a PC, but I'm not sure why it is over here like this. Anyway, over the last century, the past 100 years, top-selling drugs have been developed from natural products. Just to give examples, we have the narcotic analgesic morphine from Papaver seminiferum. Also, we have the anti-malarial drug artemisinin and its semi-synthetic derivatives, the artemether and arteether from Artemisia annua, the anti-cancer drug vincristine from the Catharanthus rosas plant, and also the anti-cancer taxol from Taxus brevifolia plant. Those are only like a few examples to show, that also natural not only this concept, but also we have modern medicine participation of the natural products in that. But the use of the herbal medicine also is growing, and there are like several factors for this. If I do have modern medicine and this medicine is very effective, why I'm going to herbs? First of all, the disappointment with the current medications, particularly with the chronic diseases like hypertension, diabetes, or even cancer, fear of safety and long-time usage side effects, and that fear might not be true. People tend to think that natural things are safer than synthetic, which is not true, not 100% true, let me put it this way. And we know that one of the deadliest poison in the nature, in the world is natural in origin. For example, tetrodotoxin, which is like a marine toxin. It's it's natural things. So not always natural things means safer. The belief that herbal drugs are safe, we discussed that, the lack of effective treatment, then peer influence. Like people might affect, like for example, you have a relative or a sibling will tell you, okay, I took this like herbal medication, my glucose went down. So you believe him, will go and try it as well. So the peer influence, then the desire to control one's own health. I want to be in control. I don't want like a physician to, of course I'm not, this is like I'm talking about the general lay men, all right? Of course, the false claims of the manufacturers, and we have to be careful about that. So a lot of manufacturers will give you, or will give like a final product and will claim it will treat this, treat that, and this is not true. It is not evidence-based therapy. All right. So we'll go back to say natural products. They play 4 significant roles in the modern medicine. The modern medicine, again, it's the pharmaceuticals or the preparations we have these days in the pharmacies. So they do provide the drugs that are difficult to produce commercially, either synthetically or biologically. For example, we have the opium alkaloids. It's very efficient from the economic point of view to obtain the opium from to obtain the morphine from opium. All right, so you just cultivate the opium, you get the capsule, you just take the exudate, which is the opium, then you isolate morphine from. And we have also ergot alkaloids as well, cardiogenic glycosides, digoxin and digitoxin, although they are synthesizable, you can synthesize them, but when it comes to the economy, it's better to get them from nature than from the lab. So, and also, of course, most antibiotics. They supply basic compound that may be modified to be more effective and less toxic. An example of that, the morphine. Morphine is used as painkiller, but it is known to be more toxic as CNS suppressant and addictive drug than codeine. So if we need codeine as cough suppressant, either to get it naturally, because codeine again is a natural product, is found in the opium extract, or the other way, believe it or not, most of the codeine in the clinical use, like codeine phosphate, for example, is derived from morphine. So because morphine exists in a large percentage in the opium, about 40% of the alkaloids found in the opium is morphine. So they will use the morphine, they will take the morphine, prepare either morphine hydrochloride or sulfate as painkiller, then they will modify morphine simply by methylating this hydroxyl group, so this is the codeine. And they will be preparing that as codeine phosphate as cough suppressant, all right? So that is less toxic and different indication as well. So we also use or used and still using natural products as prototypes for synthetic drugs with therapeutic activities as the original. This is what we call pharmacophore-related natural products. We see the pharmacophore, then we don't use the compound itself or the natural product itself, but we derivatize it or we try to synthesize something contains this pharmacophore that will give me the activity I want. A good example about that is cocaine. Cocaine, we know that cocaine is a CNS stimulant and it is psychologically addictive. However, it also exerts local anesthesia. People who take cocaine either through snuffing or like through a mouse, they do have some type of numbness or local anesthetic action on the mucosal membrane. So by studying the structure-activity relationship of cocaine, they found several functional groups, for example, tertiary amine, benzoyl moiety, and others are responsible for the local anesthetic action. So they took these functional groups and they synthesized other compounds like procaine. If you look into the structure, actually cocaine is different, from the structure. It's not considered as analog of procaine. But three functional groups in cocaine, they do present in the procaine or xylocaine or lidocaine. This is why procaine, for example, they don't have CNS stimulation, although they are applied topically, but they don't have CNS stimulation even if they will be taken systemically. However, they do exert local anesthesia. And this is why the suffix "caine" was added to those analogs to honor the role of cocaine in their discovery, all right? The fourth point is some compounds, they do exert little or no activity at all. However, they can be converted into more active compounds. A very good example about that is Taxol. Taxol originally, it presents in the bark of the Pacific yew, we call Taxus brevifolia, in a scarce amount. However, Baccatin 3, which is, I would say, a precursor of Taxol, presents in abundance. So by isolating Baccatin 3, which is abundant, and converted into Taxol in the lab, that will produce Taxol in a huge amount, in large amount. Baccatin 3 is this symbrinoid diterpene until this hydroxyl. We have here OH only. So this is Baccatin 3. It is not cytotoxic. It is found in abundance in Taxus brevifolia. So by taking this Baccatin 3 and in the lab we introduce this ester group, we convert it into Taxol or Bacillitaxel, all right, which is needed as a cytotoxic agent. Right now we have other avenues. We have other avenues actually to produce Taxol, not through the synthesis or derivatization of Baccatin 3 into Taxol. All right. So drug discovery and natural products, what is the rule? In fact, when we say drug discovery, it's almost synonyms to natural products, all right? And I don't want to stand here and defending the field because I'm natural product chemist, but this is a fact, all right? So before lunch, actually, we had like 3 lectures, and the last one, the last presentation concerning Watania, not so many, Watania coagulants, all right? When we saw that, our researcher actually showed that there is a compound isolated, and it gave like fantastic results in comparison to other clinically available oral hypoglycemic agents. So in drug discovery, nature actually, or natural product become the central or the backbone, the head and shoulder in the drug discovery programs. To illustrate or to strengthen or to emphasize this fact, in 2023, there was a report in the Journal of Natural Product showing that about 72% of almost 2,000, exactly 1,981 molecules got introduced as drug between like 1981 until 2022, which is about 40 years. 72% of those entities are developed from natural products. So either pure natural products or semi-synthetic natural products or derivatives based on pharmacophores in natural products. So natural products played some role or another in those 72%. The contribution of natural products was greater actually in the field of anti-infective agents like antibiotics or anti-cancer agents, all right? So the contribution was even greater, like 78% of antibacterial agents were from natural products. Again, I'm talking about this statistics, which is between 1981 and 2022. And of course, this is in addition to cardiovascular things like statins and also the multiple sclerosis. So a drug discovery is not really vivid dream, as you can see. I mean, they do have like opportunities, however, also like some difficulties or drawbacks. So advantages of natural products in drug discovery versus synthetic molecules. And here I'm just comparing right now, but still medicinal chemistry, synthetic chemistry is heavily needed, and I will show you when and where. So natural products have enormous scaffold. I mean, this is the beauty about it. They do have scaffold diversity and structural complexity. So the biodiversity and the biochemistry of the natural products made them attractive for drug discovery, all right? Although this is an advantage, but I'll show you also it might be a disadvantage. I'll show you later when. So we saw the past 20 years that there is like an increase in the molecular weight, like natural products with high molecular weight, with more saturated carbons or the so-called sp3 hybridized carbons and oxygen, with less nitrogen and halogen atoms, with more hydrogen bond acceptors and donors, with low C log P, which is the partition coefficient between octanol and water. It means that higher hydrophilicity, more polar. What about those? Those actually, if you are familiar with the Lebnitzky rule of 5, which predicts the orally, I would say the orally active drugs or drug-like molecules, let me put it this way, this is beyond. So it means that natural products now is a major source of oral drugs beyond Lebnitzky rule of 5. So not anymore you have to fulfill the rule of 5 in order to have orally active drug or drug-like molecule. So even molecules with more molecular weight, more than 500, this is the rule of 5, or you have, acceptors and donors more than 5 and less, less than 5 and more than 10, still you can have them as orally active drugs. So that increase was translated into more approved oral drugs over the past 20 years. Again, the advantage of natural products in drug discovery that natural products, I would say the natural habitat, the plants, the microorganisms, even terrestrial or even marine, they do optimize optimize the structure in order to fit certain enzyme, either to activate or deactivate these enzymes, because those products, we call them secondary metabolites. I mean, those secondary metabolites are not essential for the survival, are not essential for the living of the organism. Rather, they serve as, for example, defensive mechanism in competition with other microorganisms. So it is very logic. I mean, they call it nature, we call it God, or Allah. Yani, subhanallah, Allah made these things to fit those enzymes, all right? So this optimized in their habitat to serve particular biological function, for example, defense and competition. And this is why there is no wonder why most of the discovered natural products are either anti-effective or cytotoxic, all right? All right, so and I said that natural product pool is rich with bioactive compounds covering vast majority of, I would say, chemical or chemistry area as compared to synthetic small molecules libraries, all right? So if you look into the diversity of the compounds, you will be amazed. I mean, a lot of sick skeletons, and every time we're just discovering new things. All right, so what about the drawbacks? The drawbacks, we have several. Like, for example, maybe this is the major in developing natural products into medicines that pharmaceutical companies, they do reduce their programs related to natural product development medicine. I mean, they do have reasons for that, definitely, all right? So the reasons for that, the screenings or the screening of the natural products, usually it is really, I would say, not difficult, but does not go all the time right, because the available traditional screening assays, I mean, they are not created to fit those molecules of natural products, maybe for small molecules. Because it is easy or easier to study small molecules to see what pharmacophore is there, so you can design certain assay to detect the action of this compound. Identifying the bioactive compounds can be challenging as well, because most of the time we end up with extracts, like our friend who presented right now about with Tanya coagulants. He said the mixture. Then in order to identify that compound, it needs something. It needs a longer process. And is that compound previously known or not? All right, most likely it is known. So in order to have something patentable, you have to produce or isolate something new, all right? So that we should do dereplication, and this might be as a challenge in order to avoid rediscovery of already known compounds. Accessing sufficient biological material is important. We need to have sustainable, economically, I would say, acceptable supply of those organisms, either plant or marine organisms, all right? And this is why, this is the problem actually, why most of the pharmaceutical companies, they are not interested in investing money in something, in a source that will be depleted very soon, all right? All right, and of course, the intellectual property, this is intellectual property rights. This is like I would say, a very hot topic that will deter pharmaceutical companies from investing billions of dollars to develop something that's not patentable. Because you cannot patent unmodified natural product. You cannot patent certain plant. You cannot patent certain organism or bacteria. For example, you cannot patent E. coli. But you can patent genetically modified E. coli. And this varies between countries, but there is no universal law that prevents the use of something which is natural, unmodified. This is why, like pharmaceutical company, again, they are reluctant to invest several billions of dollars in order to develop something that's not patentable. The regulations, we need regulations, and actually that was placed in 1991 through a convention on biological diversity and Nagoya Protocol, and was applied or was in effect since 2014, which negotiate the benefit between, for example, producing countries. For example, today we heard about that Indian plant. Again, I'm always going back to this example. Okay, if we discovered a drug from this Indian plant, does India deserve a share of this discovery? So, like the producing countries of those natural things, now they are debating, I would say, sharing the benefit with those countries. Although the complexity of natural product structure is advantageous, as I said before, however, the generation of structural analogs, and this is very important when studying the SAR, the structural activity relationship. You have a compound, you need to derivatize it. You change hydroxyl into methoxyl, you need to put ester, you need to hydrolyze the ester, and then study the structure. This is difficult with natural products. You cannot really, I would say, you cannot, prepare a library of derivatives, okay? But it is very good in the synthetic route. So here, maybe small molecules, synthetic molecules are better in studying the SAR, all right? All right. Now, this is the whole process, like it's a summary of the process of producing single compound from organism. Simply, we'll start with the process. We have the organism, and this organism, either a plant or microorganism, and we do have actually some problems about that. For example, if you take this organism and you want to cultivate the organism in a local garden, like a medicinal garden in your facility, might not grow, or it might not produce the active constituent that you are looking for. So this is a problem. But the solution for that, we have a new method of cultivation, and also we can I would say, manipulate the genetics in order to affect the biosynthetic routes in those plants in order to continue producing the natural product of interest in I would say, the artificial environment. And this is actually, you see it a lot with the marine natural products. Like you have like a sponge or scidians, like 30 meters below sea level, and you can get it and cultivate it. However, you don't end up with the products that you need, all right? So, I mean, sometimes it is. Then you have the crude extract. The organism will be extracted, and this extraction, again, we have several problems with the solution, like a presence of natural products that are known might be there in this extract. All the presence of natural product but do not have drug-like properties. Okay, there are like a new compound, but this compound does not have a drug-like property. All right, like for example, it doesn't have the correct shape, the correct dimension, it doesn't have those type of metrics. Or the bioactive natural product it present is insufficient amount, and this is actually the big problem we face in natural product drug discovery. So the solutions are there, like new method of dereplication. If we think there is a known compound in there, then new methods for extraction and pre-fractionation as well. Then the process actually begins with the extraction, as I said, and it depends upon, we have a lot of extraction methods. I'm not going to go deeply in that, but for example, if you are interested with polar compounds mainly, you should think about using polar solvent in the extraction, because this will increase the abundance of polar compounds. Non-polar compounds will also be extracted if you use polar solvents, but the abundance of the polar compounds will be even more. Some people or some research groups, they go with extraction schemes. For example, they'll start with hexane, non-polar solvent, and after that, they will take the mark and put it again in ethyl acetate or chloroform, then ethyl acetate, then butanol, then methanol. So we have a scheme of extractions. And every extract do have different compounds according to the polarity of the used solvent. All right. So following the identification of a crude, of course, extract, with a promising pharmacological activity, and this needs to do consecutive multiple assays. So you have the original extract, you test it, it is active, okay, then I will fractionate it, either liquid chromatography or through column chromatography. So I'll be having several fractions. Each fraction should be evaluated again, bioevaluated, until I end up with a pure compound, single compound, all right? Sometimes you have or fraction is active, and when you start to subfractionate that until you end up with several compounds, none of these compounds are active. And this attributed to the synergism that is found in those compounds when they are present together, all right? So, and this is why people started to accept using mixture of compounds like herbal drugs to treat diseases, and we'll see that later. Then, of course, we said that about that. All right, single compound, we have also problem, a non-molecular target. You don't know the molecular target of this compound. Of course, that is solvable by developing several screening techniques or modules, like, for example, the DARS or the SITSA or the SEA. Those are two different assays. All right, what about the outlook of natural products? Along with the search for a new, we are continuing and we should continue looking for a new compounds from natural sources. I mean, no doubt about that. But along with that, non-natural products should be continuously developed and optimized. For example, I isolated something which is known, all right? I shouldn't let go. I mean, I should think about optimizing that. Maybe I can repurpose this compound, means different indications, all right? Of course, utilizing advances in the biosynthetic engineering and the synthesis structure. In cancer therapeutics, very important, a new opportunity or new modalities can be used. For example, it was found that cardiac glycoside, they can initiate the immunogenicity of cancer cells. So it will be seen, highly seen by the immune system. So the immune system will take care of this cancer. In other words, it will turn the cancer from cold into hot cancer. So it will be recognized and will be fought by the immune system. Herbal medicine containing complex mixtures of natural products, and this is what I said. So owing to the potential for synergistic effect of the components. So the idea of using mixtures as medicine, now it is more acceptable. However, the variability of the natural product content in plant material, like, for example, we have the ginkgo biloba. I mean, this ginkgo biloba is known, and it is used even by physicians, it is prescribed by physicians to improve the senile, like memory, I would say, loss, or, all right? So, I mean, this extract of the ginkgo biloba, now it is standardized in order to keep certain amount of ginkgolides and certain amount of the flavonoids in this extract. You cannot use any ginkgo biloba extract. So the standardization is, I would say, the checkpoint to ensure that there is no difference in the content between different extracts from different manufacturers. The advances in the characterization techniques such as metabolomics, all right, we should be used that. And of course, development of regulatory guidance to regulate the use of herbal medications is very important. However, mixtures of natural products now feasible to develop such mixture into therapeutics, as I said, because of the synergism or synergistic action. This is another, I would say, in its infancy. I don't know if I am. So, like, for example, one of that gut microbiota, they do affect the health and the disease. So some natural products are acting on certain microbiota, so isolating, I would say, one species of those microbiota, and like try to test certain natural products about that might create, I would say, some modalities to treat certain diseases as well. And of course, the advances should be used or should be considered in the direction of using the computational drug design, like for example, the development of, I would say, pharmacophore-based drug design should also be considered, and it is. Unmodified natural product possessing suboptimal efficacy or ADMET. I mean, we should reconsider them, we should modify them in order, chemically of course, this is medicinal chemistry comes now here, so it can, lead, can be developed into leads and ultimately successful drugs. Means the optimization of that. All right. So here, to develop a compound into clinically available drug, it needs, as we said, like sustainable supply, and this is the problem, and the problem can be solved, or it is solvable by synthetic routes, or even biosynthetic routes through genetic engineering of certain organisms in order to increase certain metabolites, secondary metabolites, or decrease the other one. In order to allow enrichment screening libraries with natural products, this one will enrich the libraries with natural products or hybrids or analogs or inspired molecules based on natural products. One big problem actually, and I think this is not only pertaining to natural product research, but also to other fields of research, is the collaboration between academia and industry is lacking. So I think one of the things we might think about is to have academia near from research centers, and in this case, collaboration will be there. Physical proximity of academia with research centers, or like I would say, pharmaceutical companies. So that will, I would say, that will strengthen the collaboration between those people or the expertise from those two fields. So in summary, natural products remain a promising tool for discovery, although there are like some hurdles. These hurdles might be the supply, might be the dereplication or the replication in this case, or might be the I would say the intellectual property rights. And just more work from our labs about or on natural products, and they are presented in the posters outside. So please, like, entertain yourself by visiting those posters. Like here, for example, the vulgarin. We have some work done on the vulgarin. Then also some work done on the vincamin. Also some work done on Arabian Gulf macrophiona. And this is a good poster, actually, and I got to know that the presenter of the poster won the best graduate research poster, Mariam Shamali, and another poster about carotol, sesquiterpene, and microbial metabolism. Thank you.
Thank you, Dr. Khalid, for your interesting presentation about herbal medicines, their challenges and opportunities. Our next speaker is Dr. Nada Ahmed Al-Hasawi. Dr. Nada graduated with a bachelor's degree in biochemistry from the College of Science in Kuwait University. And after receiving her master's degree in enzymology, she joined the College of Pharmacy as a teaching assistant, where she received a scholarship to pursue her PhD degree. She moved then to England, where she joined the University of Bradford and obtained her PhD by working on polysialyl transferases. In 2008, she was appointed as an assistant professor in the Department of Pharmaceutical Chemistry in the College of Pharmacy, and her research focuses on the discovery of plant natural products with anti-progressive activities targeting malignant cancers. Without any further ado, please join me in welcoming Dr. Nada Al-Hasawi.
Thank you, Dr. Fatma, for the nice introduction. Hello, everybody. I'm pleased this afternoon to present for you our research work, which is entitled Bioactivity Guided Fractionation of Withania Samnifera L. Dunal Roots Extract, and that is like application of what already Prof. Khalid explained. Evaluation of the antiprogressive effects on neuroblastoma cell line. Neuroblastoma is the most common extracranial solid tumor in childhood, where about 90% of the cases occurs in children aged less than 5 years old and with average of 2 years old at diagnosis. Neuroblastoma accounts for approximately 10% of all malignant childhood tumors, and it is the cause of 15% of cancer-related deaths in children. Neuroblastoma arises from the sympathoadrenal lineage of the neural crest, which only present during embryonic development. About 50% of neuroblastoma patients have metastatic growth at diagnosis, most commonly major sites including bone, bone marrow, and liver. Based on clinical and biological factors, neuroblastoma is classified into localized or low-risk tumor that often shows spontaneous regression, low to intermediate, that's the second class, low to intermediate risk tumor that can be surgically resected with or without the need for post-operative chemotherapy, and the last class is high risk, abbreviated as HR disease, which is often lethal. Patients with HR disease require intensive multimodal treatments, including chemotherapy, surgery, radiotherapy, combined with standard care using 13-cis-retinoic acid, which is known as azotitinone, used to drive neuroblastoma differentiation, and anti-GD2 therapies. And GD2 here stands for the dicyanoganglioside antigen that is expressed on surfaces of neuroblastoma cells. Despite recent improvement in survival durations of HR patients, greater than 50% of the patients still experience tumor recurrence and late adverse effects, where renal dysfunction, hypothyroidism, hearing loss, ovarian dysfunction, infertility, and dental issues are common. And we come back to the nature. Withania samnifera, or ashwagandha, is the shrub of Solanaceae family that has been used for centuries in Ayurvedic medicine. Traditionally, Withania samnifera extract has been commonly used as a daily brain tonic and rejuvenator for increasing longevity and vitality. Several studies have indicated that Withania samnifera may have neuroprotective, neuroregenerative, antioxidant, anti-inflammatory properties, as well as anti-cancer potential. For example, the intraperitoneal administration of a 70% alcoholic extract of Withania samnifera roots into mice that were previously injected with highly metastatic B16F10 melanoma cells resulted in about 49% inhibition in the number of tumor nodules in the lungs, with reduction levels of biochemical markers associated with lung metastasis. Also, a significant reduction in cellular motility has been demonstrated in C6 glioma cell line treated with alcoholic as well as water extract of Withania samnifera. Similarly, treatment of IMR 32 neuroblastoma cell line with 0.5% water extract of Withania samnifera leaves resulted in a significant reduction in migration rate and malignancy of the cells. This effect was accompanied by the inhibition of cell proliferation in a dose-dependent manner and induction of differentiation. It has been determined that the anti-cancer effect of Withania samnifera is attributed to a crystalline withanolide steroidal lactone known as withaferin A. The withaferin A can exert its action by modulating molecular targets by various mechanisms. The aim of this study is to perform an extensive fractionation of Withania semnifera roots using bioactivity-guided fractionation protocol to potentially identify constituents that may present in Withania semnifera that have anti-progressive effect on neuroblastoma cells at non-cytotoxic concentrations. So actually, the presentation was divided into two parts in order to draw the conclusions out of this study. So in part one, which includes extraction and fractionation of Withania semnifera roots, followed by investigating the biological activities of the obtained extract and fractions on behavior of the neuroblastoma cells with respect to their invasion and adhesion. To start with materials and methods, each of the dried cursely powdered roots of Withania semnifera as well as a human neuroblastoma Kelly cell line were purchased. We started with the extraction of the dried cursely powdered roots with 95% ethanol, and after drying, we subjected part of the dried extract into fractionation, and that is by using a gradient elution mode. Working solutions were prepared at concentrations that were calculated in a way that always obtain 0.5% DMSO as a vehicle in the tissue medium, since this is the tolerable DMSO percentage by the Kelly cell lines or Kelly cells. So we started to use the working solution in order to incubate the cells in the different concentrations of the extract as well as the fractions and we conducted MTTSA in order to obtain the non-cytotoxic concentrations. These non-cytotoxic concentrations of the extract as well as the different fractions we obtained with different polarities were used in order to conduct Coltrix invasion assay as well as developed adhesion assay, which was developed in our lab. Data was analyzed by the one-way analysis of variance ANOVA, followed by dotted test, multiple comparison test, or by students' test using the GraphPad Prism. To start with the results, extraction and fractionation of Withania semnifera, where we extracted about 1 kilogram of the roots with 95% ethanol, and the obtained weight was 51.9 gram of the extract. Out of this weight, we use 20 gram in order to, we fraction the 20 gram using a vacuum liquid chromatography technique and a gradient elution mode, where we started with fraction number 100% water, and we increased the eluent strength by 10% increment of methanol in water until we reach 100% methanol. And here, this is the number of fractions. However, for number 6 and 7, we see 50% methanol, where we actually, we did them subsequently, and we use one of them, and that was number 7. And these eluents are presented with their corresponding weights in gram. The vehicle, and that is DMSO, where we allow, after seeding the Kelly cells into 96 plate, we incubated the cells with these different concentrations for up to 96 hours, after which we conducted the MTT assay. And of course, plus the incubation with medium as well as the vehicle itself, and that was the 0.5% DMSO. To start with the results, percentage cell viability of the cells that were incubated in 0.5% DMSO, and that is the vehicle, showed nothing, no effect. There is no significant effect with respect to the control untreated cells. These were all incubated with the medium. Results of the extract using different concentrations of the extract were also again the same. The graph shows the percentage cell viability versus the concentrations, and these percentages were calculated with respect to the vehicle treated cells. where we see at high concentration there is cytotoxicity, and the effect was non-cytotoxic at higher concentrations. We use here this graph, it's like representative example or representative of the other graphs of the fractions, where it shows only fraction 1, and that is 100% water. Again, different concentrations were used for this fraction, where the percentage cell viability of those cells incubated in the different concentrations were calculated with respect to the vehicle-treated cells. So here, like a summary of the non-cytotoxic concentrations in microgram per mil that were obtained for different fractions, starting fraction number 1 to fraction number 12. Also, there is with the corresponding percentage of cell viability. In addition, the non-cytotoxic concentration for Tania somnifera extract was 10 microgram per mil, where cell viability was almost 110% plus minus 21.2. Now, we use these non-cytotoxic concentrations in order to assess the anti-invasive potential of Withania somnifera on Kelly cells, where cells were incubated for 72 hours in 6-well plane, that is with medium, as we consider as control untreated cells, and then or with the vehicle, or vehicle containing the non-cytotoxic concentrations of the extract, as well as the fractions. After the 72 hours and at 37 degrees, we re-incubate the cells with the same treatment, however, without the serum. On the next day, we resuspend the cells in the same serum-free treatments. That is, again, without serum, but with the same treatment, but without serum, into inserts here. And these inserts were coated with the BME, and that is the basement membrane extract. And that was in a 24-well plate where the wells were filled with medium containing the serum. Just to highlight something is very important regarding the serum, which actually without serum, with serum as a top chamber and bottom chamber, since the serum contained the chemoattractant cytokines and growth factors that would attract the cells in order to invade the BME. And that was mentioned by Prof. Maytham this morning regarding the chemoattractants. So the cells were allowed to invade the BME for 24 hours at 37 degrees, after which the invaded cells were dissociated from the underneath here, the last figure, underneath the insert, using buffer containing the fluorescence calcine. However, this calcine is attached to AM, and that is AM abbreviation of the aceto-methyl ester, where the viable cells, which invaded cells, will actually liberate the calcine by the intracellular esterases, and the fluorescence actually was measured using plate reader at fixed excitation emission wavelengths. So to start again with the results, cells that were incubated with the DMSO shows high percentage of invasion with respect to control cells, control untreated cells. However, it was not significant. Now, for the extract and different fractions, they have viable percentage of invasion with respect to vehicle-treated cells. So the percentage invasion was calculated with respect to the vehicle-treated cells in order to eliminate the effect of that vehicle, which is 0.5% DMSO. So going through the results, which indicate in the table percentage invasion of the Kelly cells that were treated with fractions with respect to vehicle-treated cells, shows that the highest F9, and that is the 70% fraction of 70% methanol in water, showed the highest anti-invasive potential, which means the lowest percentage of invasion percentage. And that was followed by F10, which shows also high anti-invasive potential. So this is the followed percentage. In addition, percentage of invasion of Kelly cells that were treated with extract was 65.3% plus minus 3.4. I'm mentioning this extract because it's not included in the table. Now, we use the same non-cytotoxic concentration order to assess the anti-adhesive potential of Withania samnifera on Kelly cells. Again, we incubated the cells, same incubation, medium, fecal, and non-cytotoxic concentration of the extract, as well as the 11 fractions. And that incubation was in 6-well plate, however, for 96 hours, after which we incubated the cells on fibronectin block, fibronectin which was previously blocked with heat denatured bovine serum albumine, and that is to prevent any absorption of the cells into the non-specific sites on the fibronectin. And that incubation took 40 minutes at 37 degrees, which was actually, we worked out this to optimize the maximum time by which the cells will have the maximum adhesion to the fibronectin. After 40 minutes, the non-adherent cells were removed by washing with the HBSS, that's Hank's buffer, and the adherent cells were fixed using the freeze called 100% methanol. That was at room temperature of 15 minutes, after which we stained the adherent cells with the crystal violet for an hour at 37 degrees, and after which we lysed the cells with SDS, and we transferred the colored solutions into 96 Folate to measure the absorbance, which was at 595, that absorbance of crystal violet of the viable cells. Again, the effect of the DMSO percentage cell adhesion shows non-specific difference between the vehicle and with respect to control. So now treating the cells with the extract as well as the fractions or the fractions with respect to the vehicle CD cell, again shows different or viable results, where we can see that F10 has here shows the highest anti-adhesive potential on Kelly cells, and that is 80% methanol. It means that it is the lowest, it resulted in the lowest percentage of adhesion, which was 38.3 plus minus almost 38, followed again by fraction number 9, which also have a high adhesive potential. So this actually comment regarding the adhesion, the anti-adhesion effect of Withania samnifera, where it was reported that the adhesiveness of cancer cells to the extracellular matrix depends on the cell type itself and involve oncogenes where invasion, invasive, and metastasis potential are either associated with increased or decreased adhesion to the fibronectins. It means that there is no rule actually regarding the adhesion. So the invasion and metastasis either related to an increased or decreased adhesion to the fibronectin. To the best of our knowledge, there is no studies carried out on Kelly cells to assess their relation or the relation of their adhesion to fibronectin or any other extracellular matrix component related to their aggressiveness. So from our study till now, it was shown that treating Kelly cells with Withania samnifera F9 resulted in the highest anti-invasive and high anti-adhesive effects. Treating Kelly cells also with F2, F10 resulted in the highest anti-adhesive and high anti-invasive effects. So here, next part 2, includes subfractionation and purification and identification of Withania samnifera compounds present in the bioactive fractions which were determined with respect to adhesion and invasion to be fraction 9 and fraction 10. So again, materials and methods, the dried fractions, fraction F, 9 and fraction 10, were actually dissolved in mobile phase in order to carry out their analysis and subfractionation using preparative high-performance liquid chromatography, where there is obtained chromatograms out of that for the analysis, and after this, the different fractions. This was repeated 20 times, where 100 microliter of each of the fraction was injected into the HPLC. So briefly, as we can see that the subfractionation of fraction F9 resulted in 3 subfractions, and subfractionation of fraction 10 resulted in 3 subfractions as well. These subfractions were used in order to carry out again the MTT assay. So again, we need to determine the non-cytotoxic concentration of each of the subfractions in order to determine which one is the active or bioactive subfraction which actually involve in the adhesion or anti-adhesion and anti-invasion. So working solutions were again prepared at concentrations that were calculated to always obtain 0.5% DMSO as a vehicle culture media. Again, we carried out the MTT assay, and that was for the subfractions, 6 subfractions there. We determined the non-cytotoxic concentrations which were used in order to conduct the developed adhesion assay, where the constituents in the determined bioactive subfractions out of the 6 subfractions were tentatively identified using gas chromatography mass spectrometry, where the qualitative identification of compounds was based on computer match with NIST mass spectrometry search library and comparison with data that already saved in the library. And actually, this is considered to be an application of what Prof. Khalid already explained regarding determination of the bioactive constituents in the plants. So by determination of the identification compounds for the bioactive subfractions, similar tables were obtained for these bioactive subfractions, and we identified the structures. So again, a chromatographic analysis subfractionation of active fractions. We determine here from preparative analysis by HPLC subfractionation fraction 9 resulted in 3 subfractions, and they are listed here, 91, 92, and 93, with their corresponding weights milligram. Subfractionation of fraction 10, again 3 subfractions, they are listed here with their related with their corresponding weights in milligram. We took these 6 subfractions, and different concentrations again were incubated with the Kelly cells to determine the non-cytotoxic concentrations, and we can see all these 6 graphs for the 6 subfractions, 9.1, 9.2, 9.3, 10.1, and 10.2, and 10.3 where percentage cell viability was plotted again at different concentrations. And from here, we obtained the different non-cytotoxic concentrations where they were used in order to assess the anti-adhesive potential of 9 and 10 subfractions. And it's clear here when we conducted the developed adhesion assay, percentage of cell adhesion versus different treatments. And again, these treatments were calculated, or the results were calculated with respect to the vehicle-treated cells. We can see here with a star, significant adhesive potential by subfraction 10.1, followed by a non-significant anti-adhesive effect by subfractions 10.3 and 9.2. So here, the conclusion, we have 3 subfractions that are active, and they have the anti-adhesive effect on the Kelly cells out of the 6 subfractions. So it means that we need to carry out further studies in order to identify what is there in subfractions, what compounds are there. So identification of constituents present in subfraction 9.2, and as we can see in the chromatogram here, it is gas chromatography, mass spectrometry, total ion chromatogram, TIC, and for subfraction 9.2, we have, and based on the peak area, of course, we have 2 major peaks, number 1 and number 2. So number 1 was determined to be a compound that is 2,4, it's here, 2,4 octane 4L, 5-cyclooctane 1. That is actually a compound present in a volatile oil of the Sericea ceresoid druce. However, it was the first time to be isolated from Withania somnifera. Number 2 was that compound never reported as a natural product. This compound is an artifact occurred during isolation or analysis. Now, subfractionation, identification of constituents present in subfraction 10.3, where the TIC shows again, and based on the peak areas, two major peaks. Number 1 here and number 2. Number 1 was identified to be a compound called Britanline E, which was reported in the flowers of Inula britannica L and rhizomes of the Cyprus rotundus L. However, it was the first time to be identified in this plant, Withania somnifera. Number 2 was identified to be 7-formyl 8-hydroxy-6-methoxy-3-methyl isocoumarine. It was reported as an intermediate in the biosynthetic pathway of the antibiotic canesin by the actinomycete Asparagus mellingus and has been never reported before from a plant origin. For the subfraction 10.1, ITC showed only one main peak, which is still under investigation to identify the main constituent it contains. Thus, 3 major natural products were tentatively identified for the first time in Withania somnifera. Other compounds were too scarce to contribute to the our results of the anti-adhesive activity of subfractions 9.2, 10.1, and 10.3. So, in conclusion, treatment with non-cytotoxic concentrations of less polar constituents of Withania somnifera exerts anti-progressive effect on human neuroblastoma Kelly cell line. This anti-progressive effect of Withania somnifera on neuroblastoma cells may lead to the discovery of new anti-metastatic agents that limit the spread of these metastatic cells. This approach could be very useful adjuvant treatment in patients with high-risk neuroblastoma in combination with currently used chemotherapeutic agents, where it may be possible to lower the doses of these chemotherapeutic agents as to reduce the late side effects, or surgically resected the unspread tumor by limiting their progression by treatment with the Withania somnifera constituents. This work would never be achieved without our collaborative teamwork, starting with Professor Khalid Urabi as a co-I, Dr. Nasser Faisal Tannak as a co-I, Dr. Hanan Sari, who's a senior clinical lecturer, Mrs. Jocelyn Joy, who is to be a research assistant in our lab, and myself as a PI. We acknowledge Kuwait University for financially support this research work under the research grant RP0116. The GCMS analysis were done at Research Sector Project, College of Unit and College of Science, Kuwait University, supported by grant number GS0103. Thank you for your listening.
Thanks, Dr. Nada, for your presentation. And I would like to thank our speakers for their inspiring presentations. It was really inspiring. And with that, we conclude our drug discovery and pharmacology session. And we look forward for a new session tomorrow with more inspiring presentations. So stay inspired. Thank you.